Good morning, ladies and gentlemen. My name is Jamil Galadenchi, and I would be discussing the lessons and impact from one of our in-house built solutions, which is Loomis. Next slide, please. Now, just a quick background on Loomis. We started building Loomis back in 2014/2015, and then it went fully live in 2016. Now, the problem that we wanted to solve building Loomis is right on the screen. We realized there were, large percentage of zero-dose children across Nigeria in particular. But as you can see from the data, there are other countries, and Nigeria is right at the top. Now we wanted to, come up with an innovative solution to tackle this problem, and that was the reason that we developed the solution. Next slide, please. Now, the problem that we saw in the previous slide was because of numerous challenges. Some of them, as I outlined here, are low visibility on the stock availability at different health facilities, especially in the hard-to-reach areas. Obviously, the manual way of doing things, especially in terms of reporting and data entry. And this also resulted in low accountability on the, stock whether it's vaccine processes. And there was also a high rate of data collection errors, which is also as a result of that manual entries. And then there was substantial degrees of stock outs at last mile health facilities, because these reports take time, sometimes months, for them to, be analyzed, and then the right response to be given to those reports. And this was resulting in a lot of stock outs, especially in those health facilities that are a distance away from the central slide. So a bit about Loomis, like I mentioned, this was developed by eHealth Africa to address the supply chain challenges that I just outlined, especially in the hard-to-reach areas, and to also enable stakeholders get, near real-time visibility of those stock levels and how they are utilized across health facilities in the country, and including those in transit. So we don't only address the challenge the health facilities, but we also try to address challenges on transit, how to improve how the solution works. Loomis is a suite of two applications. There's the Loomis Stock, which addresses the stock management side of the process. And then we have Loomis Deliver, which addresses the delivery management side of the stocks. So for the Loomis Stock, all that we needed to be doing was having the health facility managers and officers to be periodically reporting their stock levels and the utilizations and wastages in the various health facilities. And for the Loomis Deliver, we have the drivers or the delivery personnel to be providing status of the vaccines that are in transit. So they're able to receive delivery requests via their via the Lomis Deliver mobile application. And from that point, the application will be tracking that delivery until it reaches its destination. And, on the dashboard, stakeholders will be able to visualize the stock levels and that delivery tracking at a near real-time status. Next slide. Now, some of the information you can get from Lomis for the stock, you would be able to see the on-hand stock levels at various health facilities. You would be able to see, products that are running out of stock, which, helps in the appropriate response before we even get to the stock out stage, which is what we're trying to avoid. You would be able to see products that are being wasted during fixed and outreach sessions. And you would also be able to see the type of, cold chains that we have across the network of the health facilities, and also quantities and date of all the incoming and outgoing stocks, as well as the utilization data around number of children utilized and the amount of stocks being utilized. This all improves account management and like I said, you'll be able to see this, be able to see what of delivery containers, which is quite special. Three to four states in Nigeria, we deployed Lomis Deliver to Sokoto. We still have presence in Sokoto, and then other states that we deployed in the past is Zamfara, Bauchi, and Kano. And you could see the data there. We had over 350 facilities in Sokoto, and over 15,000 successful deliveries using Lomis Deliver, with over 11 million antigens that were involved. In Kano, we had about 277 facilities and 8.5 million antigens moved using the Lomis Deliver application. In Bauchi, 180 million antigens are delivered, and in Zamfara, 147 facilities with 9 million antigens delivered. Next slide. For Lomis stock is RI in Kano, which is also currently happening together with Lomis Pharmaceuticals. So basically, we're using Lomis to support the RI project in Kano. And since then, we've seen improved forecasting. And then we've also seen enhancement in this two together in our percent, 25% health facilities in
Right. So if anyone has questions.
Okay, thank you very much for this very good presentation. As a state person, I'm interested in these different digital solutions that you have. However, I want to find out whether it's possible to adapt this software to other things that are not vaccines. Thank you.
Yeah, actually, that's a good question. And, that's why we were, a bit meticulous in naming the application. We call it Logistic Management Information System, because the whole idea is for it to be able to be used in any logistic management process, whether it's a vaccine or other drugs. And apparently we've used that in just like what we're doing now with pharmaceuticals in Kano. It's beyond just vaccines. And if you've noticed also, I mentioned that you're able to track even your equipments with the same solution. So to answer your question, yes, you would be able to use our Lomi suite beyond just vaccines. And this is one of the reasons we recently won an award from WHO Digital Health Innovation Acceleration Program. There were almost 100 logistic solutions that were pitched, and we were among the best 4 that was awarded with that because of how robust and versatile the solution is. Over.
Thank you very much. Great work. I just have a question on the Lomis delivery system and the tracking. Okay. So there's been this whole concept of follow the vaccine to track it from the point where it comes in country to the last mile. In terms of the tracking specifically, was the tracker on the van, the delivery van that moves the vaccines, or was it on the specific vaccines like the individual vials or the packs that the vials were contained in? I just want to know how granular the tracking was. Thanks.
All right, thank you. So the forecourt Lomis delivery is on the human side. So we're actually tracking the driver, because at the end of the day, the driver will always account for what was handed over. So in the pickup point, the driver will sign off, and that would, like I say, in near real time reflect on your dashboard that the driver has accepted to have collected this number of stocks. And so the tracker would be with him, because that mobile application is sitting on his phone until delivery. The only thing we put on the container, like I mentioned, temperature sensor that reports back the temperature status of the container for temperature sensitive stocks. I hope that's your question. Okay.
All right. Okay. So we'll just take 2 more questions before we move to the next thing. All right. So please, before you ask your question, kindly let us know your name and your organization before you ask.
Yeah, thank you. My name is Charles Sohihwa. I work for Viamo Incorporated, Nigeria. Yeah, thank you so much. Wonderful innovation there. I just wanted to ask in terms of reach. I mean, one of the slides they talked about, this solution is for hard to reach areas. And we know some of those challenges that are inherent hard to reach internet, network.
I believe if you're developing any solution for Africa, or even the world as far as it's in the health sector, because you are always focused on, those, make sure that our solutions are offline capable, which means they can operate seamlessly without network, and most in that it's offline, so that you worry what to do when there is no internet. So our systems operate deliver because we expect the driver is expected to move around. It is always hoped that he would eventually at one time be within an internet coverage. But even with dashboard, actually knows the status of the information you're seeing using color coded, UI UX engineered features, so that you can tell whether you are looking at a live data, whether there's a transition happening. All that is being taken care of on our dashboards, just to make sure that there is no any contention between the reporting point and the viewing end. Thank you.
Okay, thank you very much. My name is Tulu Anilatula from Sidani Group. I want to ask specifically about Lomi stock. How did you overcome, or how are you overcoming the human constraints with uptake of digital technology at the facility level, especially that such that you're able to record 78% reduction? That shows the network has really used this technology. How are you able to overcome challenges of saying no data, no phones, and the like?
Yeah, thank you. I think change management is always part of our project implementation process. We are always a system with an innovative idea that could probably be new to majority of the people there. So we put in place a lot of tools to make sure that that change is seamless. We have rigorous in our training programs. We make sure that we do hand-holding sessions, making sure that when we leave, we have champion to take. And we also build a platform that we call the e-learning platform, which I hope in the summit will be able to present guides and trainings for potential users of most of the solutions that we do. We also have a live 24/7 help desk facility where our clients, partners, and stakeholders can always reach out just to make sure that we don't leave you and never turn back. And just to make sure that that usage afraid because of the timing, I would not have strategies that we put in place to make sure that we record, including engagements and the likes. Thank you.
All right, thank you very much. Can we please give him a round of applause? That's a wonderful presentation. If you check your folders, you will see postcards, and I think you will see Lomis, and so you can get more information about that solution in the postcard. And if you don't have it, most likely it's going to be at the registration desk outside, and you can go for it when we're going for the tea break or to take pictures much later in the day. All right, right now we're going to be bringing up someone special in our midst. He is the country director at DataFi Project. He has years of experience in program design, implementation, and evaluation. Please join me as we receive Otse Ogori. Please, with a round of applause.
Thank you very much. Good morning, everyone. So I want to sincerely apologize for coming late. I'm just coming from Nigerian Silicon Valley, Lagos, and I got my flight delayed for about 1 hour, 15 minutes. I should have been here earlier. So apologies once again. It's so great to be in the midst of a lot of tech guys. The room is exuding a lot of tech exuberance, and thank you to the last speaker that spoke about the innovation, the Lomis innovation. I think it's a great one. And particularly just to appreciate everybody that's here, I will not take much of our time. I have a speech to read. Or using the current exchange rate as low as 64 cents. So these are startups that are actually revolutionizing the healthcare sector in Nigeria. And you and I are the ones that are actually doing that. So I think we deserve a round of applause here. One other area is the look at predictive analysis, which will leverage historical data to identify patterns and make predictions about future events. In healthcare, predictive analytics can be invaluable in identifying at-risk populations, predicting disease outbreaks, optimizing resource allocation. One very key area, particularly for the Data5 project that we are currently exploring and trying to see how we can bring to scale, is artificial intelligence and machine learning. These have the potential to bring in mega revolution into the healthcare delivery system in Nigeria. AI-powered algorithms can analyze vast amount of data, the amount of data that you and I cannot actually analyze. An AI-powered algorithm can help us do that. And not only accurately, but be trained to predict treatment monitoring. One of the things that, like I said earlier, we are trying to implement the LAMIS Plus system is to train models that will help us identify people that are likely to be positive to HIV treatment, to HIV testing, and thereby increasing efficiencies, reducing wastages, and help us to be much more, to implement better with fidelity. We are currently looking at implementing that. There's a team that is actually working with the Data5 team. We have a team from the US in country currently supporting the Data5 team this week to help look at this aspect. And we believe that mainstreaming this into the healthcare system, mainstreaming this into our electronic medical record will help actually create synergies, improve treatment outcomes, and create the strengthened healthcare system that we all envisage. Now, having said all this, we know that there are challenges that we all face in terms of data solutions. So Nigeria has made commendable progress in adopting digital solutions in healthcare. However, there are challenges that we still need to address. To address these challenges, Nigeria must embark on a comprehensive data revolution in healthcare. And this will include, but not limited to this, data collection and integration. In Nigeria, we collect a lot of data, and we collect data on one client from multiple points. We are not integrating these sources. We need to see how that can happen. And having tech guys in the room, it's a challenge that I'm throwing to the tech guys in the room. It's something that we can do. How do we do it? It's also one of the big challenges. Ensuring data quality is paramount to drive meaningful insights and make informed decisions. We need to strengthen our data quality assurance mechanisms. We need to include regular audits. Validation processes need to be strengthened, and the training need to be strengthened for data collectors, analyzers, and as you may have it. The other point is looking at data analytics and decision support. Collecting data and analyzing it is just the first step. Or even collecting data and integrating it is just the first step. Now, there's one client that suffers from tuberculosis. That same client is likely to be HIV positive. That same client is likely to have an episode of malaria. That same client is actually likely to develop NCDs, non-communicable disease like hypertension, diabetes, as the person begins to age. What can we do? Is the question to the house. I don't have the answers here. Nigeria needs to also invest in training biostatisticians, epidemiologists, and make sense of this data. The other thing that is a challenge is when we get this data, we analyze it, we make sense of it. How do we transfer? We need to disseminate our findings. What platforms do we have? What systems do we have to disseminate this kind of data? And that's why I particularly applaud the EHA team for actually taking this a step further, holding them. They also do. It's an avenue that I see potential in the way we can actually disseminate what we are doing as a country to the larger Nigerian society and also to the international community. Other challenges includes infrastructure and connectivity. We all agree. You wake up today, just by giving an example, and this is not to spite the bank, but there was a bank that upgraded its online platform. I think about 2 weeks ago. We all got text messages of how we should anticipate that. Then we think was both of them, because a lot of our good hands, our political climate of the country. Now, what do we do with the existing ones? Are we training them for them to also japa, or we are training them to sustain them in country? The Nigerian government enterprise architecture, or the NGEA, a framework of Nigerian Technology Development Agency, that's NITDA, has within its key structures a security reference model, which is a sub-architecture of the overarching enterprise architecture that enables security standards, policies, and norms consistent with international best practices to be developed and followed for information technology in Nigeria. We are happy to say that for DataFi, for the system that we support, we've been engaging with NIDA, and NIDA has actually provided the leadership that we need in various ways. Capacity building and training, I've talked about that. We need to strengthen capacity. We need to retain the knowledge that we build. We need to sustain, and we also need to challenge them. We also have issues with interoperability of disparate systems that are meant to collect data on the same disease area. Sometimes they're not even interoperable. They speak to each other. Talk more of, these are also not interoperable. So with systems to handshake. Speak to themselves, so that we know that when we collect data for one individual, we are collecting data for one areas. One other challenge that was unique identifier 18-month period, it becomes challenging. Their records show that a child starts immunization, but after about 3 months, you no longer see this child. Now the question is, what do we do? How can we make this better? How can we ensure that this child is tracked, or the mother is tracked from when she's pregnant until when the child becomes? Happy to report that DataFi is already working with IHP to see how we can also close this gap. Data solutions can help address health disparities and ensure access to healthcare across Nigeria by analyzing demographic data, socio-economic indicators, and health outcomes. Nigeria can identify vulnerable population and design intervention to bridge gaps. There's a huge potential by just using data, by using technology to identify what the government can focus on. And if we harness that and we all synergize our efforts, there's a lot we can do. There's a lot potential. There's a lot in all this. We need government. In conclusion, data solutions have the potential to revolutionize healthcare delivery in Nigeria, to drive the adoption and successful implementation of this solution in Nigeria health system. Government leadership, support, and collaboration are paramount. The Federal Ministry of Health, with its departments, agencies, should prioritize investment in care information systems, public-private partnerships. The private sector here is very key. There's a lot of resources in the private sector. Government can partner with them. Government can partner with NGOs as they currently do to move this forward. Finally, Nigeria's healthcare system stands at a pivotal moment in this journey towards optimized care through data solutions. The integration of data solution holds tremendous potentials through the implementation of electronic health records, information exchange, telemedicine, and the utilization of data analytics and artificial intelligence. Nigeria can overcome the challenges it faces in healthcare and pave the way for a brighter and healthier future. I'm particularly excited about what Zipline, I don't know how many of us know about Zipline, what Zipline is doing in Bayelsa State. And they do some logistics using drone technology to deliver medicines and blood samples and everything to rural communities. They use drone technology it and look at what is something that can be scaled. Optimized care is a reality for all Nigerians, regardless of their geographical location or social economic status. So I want to thank you very much for your time, and together we can do this. Thank you.
Thank you very much for that presentation. Due to the fact that I would like to be on track with time, we won't be taking any questions, but when we go for our tea break, he's around. You can walk up to him and ask, groundbreaking questions. All right. So right about now, we'll be taking he's the senior enabled, an expert in digital health and technical interoperability with over 20 years experience, and I believe he also shared with us and laudable. And
yeah, thank you very much. I'm just testing the slides. So I work for Health Enabled for most of the work that we do, and Health Enabled is a South African non-profit, not in things of strategy and assessment of men improve their digital implementation through, and I even doing one in Lagos State, working with Blueprint. But I also work with other network members because in the last 4 years, I had said this earlier, in the last 4 years, I've been University of Malta, where we focus on digital health interoperability specific. So that's me. And today, I will just use this opportunity to share a bit about my journey, how I got interested in digital health interoperability. I know that every conference you go to, and for me, the first one, a yearly ritual for those of us in space, that I see a lot of people in the room already, that I come to that ritual. We go to the UN and we discuss. And something, of course, the organization I was working then with of K2 in 2013 piloted it. It was supposed to be helping Shopee at that time. They work the projects deployed to give conditional cash transfer. One of that strategy work was the enterprise architecture for Nigeria. Oh, sorry. So that's the strategy. It was launched in 2016 at the enterprise architecture. And I'm trying to tell a story. We are going to understand why I am frustrated, because at the time we had all the dreams that you see this strategy. By 2020, we will have all of the heaven and earth. The core of that implementation supposed to be was collecting actual individualized patient data. And we had a lot of other systems. At the time, we did an assessment and we saw 67 tools at the time. I know that was when I connected with Atuma as well. Okay, so that was our enterprise architecture. We were dreaming of big things for the country. Please don't touch the laptop if you don't mind. Okay, so this is the interministerial governance that came together to create a steering committee. So at this level, you would think that, oh, everything is going to work because the Minister of ICT and the Minister of Health came, they started a steering committee and everything is supposed to work after them. But after this, nothing happened. And then, oh, you would think somebody in the room may be thinking, okay, this is just a federal thing because implementation happened at the state level. So how is it going to even work? But remember, something I didn't mention was that before, at this time, we had worked with the state level to endorse the document. So we brought the commissioners of ICT and the commissioners of health and their directors, 36 of them, to Abuja to discuss this over a 2-day period, and then went on to validate, went back. The National Council on Health, many of you in this room know the National Council on Health, it got endorsed. Okay, it wasn't still enough. So this is what's, so that's the whole story of how I got interested in digital interoperability, and where are we now? So this is what the current situation of things is. You look at the systems, the information is flowing from different directions. There's the primary healthcare board, there's the LGA, there is MPHCDA for the same primary healthcare data. Even within that, you want to do drugs, there's the state is doing some kind of drugs, the partner is doing a certain number of drugs, not the essential drugs. Some are doing essential drugs, some are doing just tracer drugs. So, and they are using different systems. I'm just talking of logistics, and you could even do that for then expand to private sector, the levels of care, secondary, tertiary, and then the labs and the pharmacy. You will see how complicated this is. Now, when we talk about interoperability, there's something we often miss, because the kinds of data determine the kind of investment that you need to make. Traditionally, most people will look at jurisdictional information, so like states aggregated information or LGA a private hospital to another private hospital. They don't need that aggregate. In fact, recently I was talking to a general hospital in Lagos, a really, really successful one, and they were telling me how they were completely offline and were good. They do their backup offline. They are offline in everything. They're not even connected. And then I started reevaluating. Is it really valuable to even do interoperability? Or whose value is it? Because if the hospital have saved money, they've improved how they treat their patients, they've done everything. So why really bother about interoperability? And many of the things here, we may think that it's a digital problem, but it's actually a process problem. Because if you look at how the data flows, many of the current data flow process are not even correct, even with the paper flow. Because some people will send to PHC board, some will send to the DHIS, to the LGA, to send to, and it doesn't just work properly. So maybe the first thing is to stop and correct the paper process before we start to digitize. Because if you digitize without correcting that process, you will move all of the problems that come from that inaccurate process into the digital system, and you'll still have the same problem. Of course, yes, I've talked about this kind of data, but again, you also now have the digital, the patient level and clinical level data where you manage clinical information. And of course, this is much more complex, much more expensive. We talk about data quality. We want to see what are the health system goals. For if you are in IT like me, you have made a lot of mistakes where you go and you are telling them about how technology is going to do this and do this. If you've not linked it to these goals in the health system, how it's going to improve financial coverage, effective coverage, the quality of care, which is really what EMRs and point of care systems that are collecting individual level data are doing. They are trying to improve the quality of the information that is collected, or if it is to drive demand up. All of these are things the health systems are looking at. So a health system manager is looking at this. You are looking at your EMR working, and there is always a disconnect. And when you look at all of these, also understand that many of the facilities are still using paper. Some are digitized, fully digitized. Some hybrid digitized, meaning they use digital and paper. Some are completely. So all of this compounds the problem that you have when you want to do interoperability. Okay, so you manage to do interoperability, like in his earlier address, he was mentioning the integration that they have successfully done. And let's assume you have two systems that you want to interconnect. Yes, it's going to be easy. It's just one integration point. But if you have 5 systems like we have here, you will have something like 15 integration points. And that's all of the problems that you encounter in integrating one system interoperability projects. Of course, we cannot talk and you can see the myriad of standards. And I can tell you, for instance, one of them is the ISO TC 215 that Nigeria adopted 32 of the standards in 2019. No movement. Well, I mean, let me not say no movement. We have made movement, but not appreciate that we will make. The question we keep asking is how many people have looked at that standard, do even know the standard exists, how many has looked at it, how many has taken their time to read it. And of course, that's a question for another day. So yes, there are very many different terminology systems that you can choose from. How do you decide where and how to choose from? I'm driving somewhere. We're going to look at. So that is the enterprise architecture. What do we do to start building an actual thing and not talk about it in PowerPoint formats? The question that keep arising is, yes, Data FI has integrated the systems within their platform, but is it but they are finding it difficult to integrate system with other platforms. What could be the reason? The reason it's easy to see, and I can to integrate. They figured out that, okay, who will host this database of integration? Is it going to be GTB? Is it going to be First Bank? There's no other bank who allow the other because the other is not a trusted party. In terms of technology, that's how we see it. They're all on trust party. So there's only one way to integrate. You have to have a central authority that manages the integration. Everybody pulls the data there, you pull it out. Then, but who will be that person that will manage that? Because that person becomes very powerful. And that is what is happening in the health sector as well. Who will be that central authority? The question then is, there are different models for managing how this works. That central authority doesn't seem to work now because we can't seem to find. Of course, the banking sector solved it because they all came together and formed an organization called NIPS, and they are co-owners of the organization. So there is a central authority co-owned by all the banks, and CBN manages how the information is integrated. Well, we can try that model in the health sector, but you see, health sector is much more complex. It's not just 26 organizations. We're talking of hundreds of organizations. So how do you manage it? And the type of data different organizations need is totally different. It's much more complex. Of course, I'm preaching to the choir. The question then is, should we consider the federated model where each organization hosts their own database and then share information as they need? Of course, this complexity, I'm going to come back to that. We have the patient control model, of course, that goes behind what the developers or the owners of the system provide. We also have the decentralized model. Of course, that's where I did my PhD. I would have loved to focus more on that area, but I know the realistic thing that this is not the area. It's the decentralized model. It's based on blockchain, but we are not ripe for that yet in the country because we do. There are many things that needs to be in place. But the federated model is what somebody like me believe is something that will work in Nigeria, because you want the PHC boards and the different organizations that do their work to keep their databases, manage their patient information, but have a central master patient index that will link all of them. So giving the PHC board, the PHC board, the DHIS2, the pharmaceutical, the laboratory, other regulators, or the LGA, everybody just figure a way to, who has existing system, manage it, but then have a central system that coordinates which information which organization wants and how. So that's I am seeing it. We're having conversation around it with some other colleagues, but let's see if that will come to reality, practical. How do we move from these PowerPoints that we are discussing to it? And the question that always arises, okay, let's meet and discuss. But if you discuss interoperability and you are not talking about coding, you're talking about code systems like those terminology systems that we talk about, the clinical codes, you are not even in the surface. So this is a call to action for us. Let us make sure that when we do work on interoperability, projects, we are not just working on it at the superficial level because it's much more complex. Of course, one of the technology standards that helps to demystify integration is FIRE. So FIRE, everybody talks about it because different things it does. Of course, cases where you don't necessarily have to use FIRE, but if you are using, if you are doing patient level integration, then you have to consider using FIRE because many of the frameworks are already there. For instance, it has a method for patient identifier, a method for structuring organization information, method for different resources that you would need. It's software agnostic, meaning it's the data structures that different software use to exchange information across different platforms. This is a technical discussion, so I'm veering into the technical now. So, and you must think about how to manage versions, conformance. What does that look like? Because if you want to conformance, you have to build an actual server where the community would need to test their conformance information, including it supports terminology, obviously. So you cannot say, I'm using FIRE, so I will not use Nomad City or I will not use ICD. I think these two things are, they do different things. So, so that's a bit of the maturity model, model for the FIRE implementation. So if you want to adopt FIRE, if you're new to FIRE, one of the things that you may want to do is to look at the maturity model. Some of them are normative and the other is in production mode. The other is in prototype mode. Some are ballots and work group has verified or community has used it, and then the ones that are still in their early stage. So we encourage, if you're looking at resources, because FIRE resources when you try to use FIRE. So for you to decide which one to use, definitely consider using the maturity resources. I mean, always have to make sure I will close on this note that a statement by somebody I don't know, but it says that if you want to go fast, go alone. But if you want to go far, go together. So I would say, okay, before I end, I will also point out that another work I do is the Digital Health Interoperability Network, a network of colleagues. I've spoken to colleagues at eHealth Africa already around about this. So we are working on having this kind of technical interoperability discussion, just focus on just interoperability, not digital health. And would love to continue this conversation with many of you for now. And thank you very much. God bless.
A round of applause for him. Thank you. I like how you said we can outside of the hall. Right, have more presentation, then we will go out, have our photo session and observe a tea break. But just before we do that, I'd like to recognize the presence of Mr. Emmanuel Atuma, the Chief of Party of Jabi, representing the country director here present. Can you please give him a warm round of applause? And I'd like to invite him up to give us a short goodwill message. Thank you, sir.
Thank you. Good morning, colleagues. My name is Atuma Emmanuel. I'm happy to be here, standing on the shoes of Dr. Oniri Adetiloye, the country director of Jabi, Nigeria. And so, the person, I am personally inclined to digital health solutions. Prior to my being the chief of party for the RISE project, I had actually led a digital health project for maternal child health in the country. Projects, and this was the times when the issues of pilotitis were still be the issues of pilotitis in health solutions when I went to scale. We are currently in a digital in a technology. And definitely, we cannot remain in the analog world. And one of the things we have seen is that, and we recognize so, is that the data space, the EMR space has become an entry, a key entry into the digitalization for health. And we are that is not the whole space. That's not the whole gamut for digital solutions for public health. So Japago is very happy to identify with eHealth Africa on this summit that, all of us together again to share experience to what we know and what we are doing and what we ought to be doing. We've heard from Ogori, we've heard from Emeka, and I'm sure we'll be hearing much more going forward. For us at Japago, we are focused on embracing and enabled health delivery services. Health enabled, whether it's for data, whether it's for diagnosis, whether it's for patient satisfaction and care, the whole space of what technology can do to enable access to health services, the telemedicine, the Mobi that we talked about, what's it called, Mobi Health. Those are enablers that continues to break barriers to health services and access, and also reduce the strain on patients, on clients, having to have unnecessary, redundant waiting time at facilities. So again, for Japan, we are clearly, attuned. And what we do across all the countries where we work is try to be involved in also promoting new markets for digital solutions that will be either for diagnostics, for care, either for post care also. And in this regards, we are also happy to be a part of those who are introducing solutions, including machine learning, introducing solutions, including using social media and other digital space in improving access, in reducing barriers, and in also bringing satisfaction to health workers. So when we look at digital solutions, we should not look at it only from, interpretation gathering, but what about the health workers? What will ease their work? How are we working towards that? How are we introducing health-enabled technologies that makes their work faster, that makes their work more enjoyable, and reduces this? So I just bring greetings to say that we are here to share in the learning. We will join, we have one or two presentations on how we are trying to improve case management for HIV and AIDS, iterating with machine learning also, and also how we are using social media and other digital space to improve here. So we're hoping that together we'll then jointly and we will be able to improve. But an area of concern is the national infrastructure that has been going. And concern is the national technology. With the government persons or people represented here, NIGDA, NCCs, and co, that government accelerates backbone infrastructure across the country as quickly as possible, not only because of public health good, but for general acceleration of the economy of this country. And so we are also hoping that as we drive this through health, that the government also expands this, ensure that there's a strong national infrastructure across rural areas particularly. What we do is that we will not disenfranchise a rural woman from accessing specialist care because she's now in an hard-to-reach environment. Even in that hard-to-reach environment, she can remain there and access, specialist care that they all will travel distances to come and do. So I hope that we also, as we articulate our learnings and experiences, that the government finds that enabling support, creating that enabling environment. So I want to thank you for having us here. We look forward to a great deliberations, and of course we'll continue to be on and offline in our discussions and experience sharing. Thank you.
Thank you very much, sir, for that insightful sharing. All right, quickly, I'd like to just recognize the presence of the CEO of ECUS. ECUS stands for Excellence Community Education Welfare Scheme, in person of Mr. Andy Ayo. Oh, he stepped outside. All right, so yeah, just celebrate him in absence. All right, so we're just going to have one more technical presentation, after which we will go outside, have a photo session, and then the tea break, and then we'll converge back here for the panel session. All right, join with me as I bring up Mr. Ondura Evans. Please, can you give him a round of applause? So while his presentation is coming up, he's a trained project management expert with over 13 years of experience in strategic information for health systems strengthening. He currently serves as the Deputy Country Director at Datafy Nigeria, a role where he leverages his expertise to implement robust analytics and health informatics strategies. Please, one more time, please give him a round of applause.
All right, thank you very much. So I think first of all, I have to appreciate the welcome we've had so far and the Africa for having this session. So I also have to make sure that the formation speakers, Chuku, Emeka, and Dr. Gori have actually made my work very easy. They presented most of my presentation, so I know Ote really sang a lot about Lamis Plus. I think if you counted the number of times he mentioned Lamis Plus, it was around 10 times. So it makes my work very easy. 9 times. Okay. I was just trying to round it off. All right. So just to give you a history of Lamis Plus, I think I will really not focus much on some of the areas that have already been mentioned. So Lamis Plus initially was a system started by FHI 360 under the GAIN project. And I think also FHI continued its improvement under the CEDAS project, and the version 2.0 of that version came of that system out. I think I can move the slides. I'm already in the slides. Yeah, sorry. Just move to the next slide. I'm on the history slide. Yeah. So I think in sometime in 2019, we were USAID mandated Datafy to conduct a little bit of an assessment of the systems that were supporting the HIV program at that point. And Lamis Plus being one of the system, and also we reviewed OpenMRS at that time. So based on a lot of investment that USAID had already made on Lamis, we came up with a also meet international standards. Next slide. So one of the key areas I just mentioned, we came up with the architecture that was adopted was to respond to the digital principles of digital health development. So one of that's to ensure there's collaboration, adherence to privacy, security, built for sustainability, and basically all the principles of digital development. And also I think one of the frameworks that Chuku already mentioned, the national health strategy that was anchored around 2015 to 2020. So that is where we anchored most of our implementation on. I think you need to move the next slide. Sorry, I'm too fast. Move to the next slide. Next one. So I speak too fast, sorry. You'll have to forgive me. Yeah. So part of it, one of the key areas around Lamis Plus that stands out. You know, we've been talking about open source systems. So OpenMRS is a community that started somewhere in Kenya and grew up to a global community. So we want Lamis Plus to be the Nigerian-owned open source platform. So as it stands right now, most of the code that we've worked on are actually to other disease areas. And part and parcel of that, we implemented a workflow that helps both point of care and also data entry. So workflow were catered for in the system design. And just as mentioned, what is more important is the data user aspect. So we are ensuring that what the user experience, the data use of this, it implements the data use where it generates the reports that are necessary both for government, donor, and also at facility level to be able to make necessary decisions. Next slide. I think just to reiterate what Shuku mentioned, there are a lot of standards that we had to adhere to while developing. So based on the international terminologies, exchange standards, as mentioned, the modular architecture, and also the open source, and looking at the making the code available and to be able to for a community to really contribute. And also a community-driven approach. So we are also at an inflection point where we are trying to strengthen the community of practice around this system to be able to have more contributors and to strengthen the system as we go. And also align to the data security guidelines, international, national. So just as you mentioned, all of us, we're having a challenge with the identifiers right now, nationally, across most systems. So also we try to align with the national identification standard that are set by the government, and they also exchange procedures and protocols as we move forward. Next slide. So in terms of the architecture, I don't think this is much of an interest, but just for the few that are interested in the technical side. So the backend is just a Java Spring Boot, and the front end is, we made a, let me just say, a dynamic front end that you can have. If you're in terms of technology, you can use it React or Angular and you plug it in. As I mentioned, it's modular. So whichever module you develop, so long as it's aligned with the architecture of the system, you can just plug it in and you expand it just not only to serve HIV, but also the other disease areas. Key to this, there are some core modules that come with the system, basically things like patient registration, check-in, admission. So we are actually expanding the OPD section of this system so that it's fully utilized in full continuum of care from in any primary healthcare facility. But also the other modules that come in, HIV plays as one of the modules. We have modules that integration modules, triage, PMTCT, and key population. So it's a microservice. So basically any disease area is a service within the system. So interoperability, as mentioned, is a song that we don't stop. So there are a lot of national systems that we have to adhere to and connect to. So the NDR being one of them, there's LIMS, there's DHIS2 platforms and other logistic management systems. So I think there's an interest around LOMIS that we'll have to have a conversation around, and we see how that will play within the same ecosystem that we're operating under. Next slide. So as mentioned, one of the key strengths of this system is the decoupled module architecture. So this one enables you and it scales to any disease area. So if you are a developer and you're part of the community and there's a disease area that you want to track, and HIV is not necessarily your key area of focus, you can develop a module and plug it in and use the system for other disease areas. And also there's the biometric support. So basically this is a national standard, and in terms, if you work in the HIV field, then this is a really big push right now for us to have biometric supported in our systems. So we are enhancing the user experience, the UI UX. So these are very collaborative process through the community. The community brings in a lot of ideas. So it's something that we always continue improving based on feedback. So as mentioned, there are multiple front-end languages. You can use React, Angular. So far, React and Angular have already been tested and they work. So we are looking to expand that to more. So it depends with the strength of the community so that they can use the system fully. As mentioned, it's user-centric, and we are driving towards data quality. So most of those decision support mechanics are already put in place. Next slide. So as mentioned, I think the clinical decision support of the system. So we are really trying to work to strengthen this, and also looking at alerts for both the clinicians and also expanding that to the other users of the system. So basically, an alert for allergies, drug dosage, alerts for just basically viral load treatment failure, just so that when some initiatives provided sort of care, and they're able to have these snap decision making alerts with them. Next slide. So these are just some of the sample interfaces. You can click to next. And also just to mention, there's a demo site for this. So I think during the breakout sessions, we might as well share that link and people can access this. Next slide. So where is the roadmap? As mentioned, it has been a long journey, and I know I'm glad some people in the room have been part of this journey. It has been a very iterative process. Part of our SDLC was to really be agile to the user requirements and the user needs and ever-changing dynamics within our implementation, and also the context on Nigeria health system. Nigeria health system is very unique in its own way, not as the rest of the other countries that are very monolithic in nature. So we had to really put that into context. So we've been having this iteration since 2019. So, and glad right now to speak, this system has already been deployed to 617 facilities across 17 states in Nigeria. So that was a big milestone for us this year, and still work in progress. And I'm glad some people within our community of practice are even seated in here. So yeah, so those are the major milestones we have on the system. So any further questions, I think I'll be available to answer. And our choir master, Mr. Ogori, will always be here, and we continue singing the song for Lab Miss for us. Thank you.
Thank you very much for that wonderful presentation. And I think I need to also, on your behalf, thank Mr. Ogori for helping you this far. All right, so right about now, we're going to have our photo session, which will happen here where I'm standing. Okay, yes. Okay, oh, great. All right. I was recognizing Mr. Andy, the CEO of EQs, while he was outside, but he's right here with us. So can you just stand up to recognize? Can you please give him a round of applause? We're glad to have you here with us, sir. All right. So the tea is ready outside, but just before we go, I'd like us to have a group picture here. And we have just two orders of photograph. The first order is for everyone to take the pictures together. And then the second order is to have all the technical presenters and keynote speakers take the pictures with the ED of EHA. So, all right, so let's just begin to migrate towards this area. I'll need some technical help. All right, so we're about to get into the second phase of this meeting. Can I have our attentions, please? It's very important. I'd like to have your attention. All right, so we're going into the second phase of this meeting, and this time around we will be having a panel session. We will have 3 of the technical session presenters, 2 of them and 1 other person join, and we're going to have an interactive session, after which we will take questions from the house. So I'd like to invite the communications manager at eHealth Africa, in person of Judith Owojo. Please, can you give a round of applause?
Good afternoon, everyone. I'd just like to take time to welcome you again to the Insights Learning Forum. Welcome. So it's Insight Learning Forum 2023, and our theme for this year is Digital Innovations in Public Health Practice, Lessons and Impacts. And incidentally, that's also the topic for our panel discussion today. So without wasting much time, I have an expert panelist that I'll just go ahead and welcome to the front. So in no particular order, I'd like you to join in, first of all, to welcome Evans Ondura, Deputy Country Director, Palladium Delta-5. Welcome, sir. And next, I'd like to welcome Mr. Abdulhamid Yahya, Deputy Director at eHealth Africa. And last but not the least, I'd like to welcome Mr. Emeka Chukwu, Senior Digital Health Advisor at Health Enabled. Welcome, sir. Thank you so much. It was almost an all-male panelist, but we didn't let that happen, so I'm here. You're welcome to Insights Learning Forum, and I want us to discuss the theme of the year in more detail. So we know that in recent years, the intersection between digital technology and public health has sparked a lot of interest in the field, in the practice, in the public health practice, from the power of artificial intelligence and data analytics to the potential that we hope to find in telemedicine and mobile applications. You know, I know that we can all agree that digital technology has definitely changed the way we do things in public health. It has changed our delivery and even our public health outcomes. So I'll jump right to the first question, which is for you, Emeka. And the question is, how has the integration of technology improved the efficiency and effectiveness of public health initiatives?
Hello, I'm glad to be on this panel. So thank you for the opportunity. So I just want to say that in response to your question, integration of digital tool has a lot of value add. If we start from public health information integration, and a typical example will be immunization and information integration, where this has happened, you are easily able to detect outbreak and respond to it quickly, even before it becomes an outbreak. You detect if you are using case-based information system collection, and that information is available for the decision makers at various geographic levels, then you can easily see a spike in disease movement and know what to do even before an outbreak is reported. Thanks.
Okay. Thank you. Thank you so much. Especially detecting outbreak. I know that when the COVID came, it was a problem because it always looks like we're not prepared. So this has laid a very good foundation for our next question, which is for Evans. So what are some of the examples of successful digital health interventions, either from your organization or other ones that you've worked with, that have had a significant impact on public health outcomes?
All right, thank you, Judith. Yeah. So there are a lot of them. I think most of the speakers even before really mentioned a lot of them. But key to this, they are very, if you look at the advent of COVID, there was a lot of GIS-enabled technology that was really pushed around. For example, there was a lot of Google mobility data to look at the movement of the population and overlay that data with any other disease area like COVID. So one that gave the government the opportunity to have interventions for based on that mobility. And I think we did some network analysis using the Google mobility data, and you could see restrictive movements were affected when the government put some restrictions. For example, you'll find there's a surge in people staying in their estates. If you look at it, then there was a reduction in where people are staying in the public places like public parks, shopping malls. So that kind of technology, it was really deployed at that point, GIS-enabled technology. So, and also I think also the preemptive, I think we mentioned some of the preemptive technologies like machine learning, predictive analytics, AI, and also deploying Internet of Things, where we were doing a lot of web scraping to really have information from the social media, just to make sure that we're able to preempt some outcomes and detect threats, and also denounce some of the rumors that were coming around from the social networks. So part of it, for example, I'll give an example of, I think there was a WHO tool for estimating supplies that were required for COVID-19. It was one of the tools that used some algorithm just to make sure that based on some inputs and parameters, we are able to articulate or project some of the resource requirements that ranging from human resource, supplies that are required for the intervention for COVID-19 response. And there are many more. The University of Pennsylvania had a predictive model where they were using that to look at basically projecting the number of COVID-19 cases based on location, some parameters to look at social economic factors, and they're able to use that to project based on these factors and the routine cases that are coming. They're able to project some of the COVID-19 cases that were coming in. These are a lot, and even pun intended, eHealth, and actually there are a lot of eHealth applications. We've talked about EMRs. We work a lot just to make sure that they are scaled based on even integration into both national system and international systems. One of the key areas that NCDC and which Nigeria really did well was to, in terms of verifying, for example, valid certificates for COVID-19, you had to integrate with the global network. So basically, those are some of the key applications that were out there. There are a million. Is a topic I'm very passionate about. We can continue on and on this. That in the context, I think also just lastly to mention, which we keep forgetting, Africa in general, we have a lot of, I think we are the epicenter for a lot of strategic documents. You'll find Nigeria has a very good Nigerian enterprise architecture document. And even right now, NCDC, Africa CDC in its own wisdom has come up with a digital transformation agenda that we need to localize as a country right now. So these are some of, they took in based on some of the experience. There are a lot of documents, plethora of them, very beautiful content. Operationalization is a different thing. We can discuss that as we proceed. But yeah, there are a lot of beautiful things that came out. Thank you.
Thank you so much, Evans. I think that there's one good thing that COVID did was to force us to think, to be creative. So thank you for all of the solutions that you have mentioned. I'm always very excited when we have preemptive measures rather than, when we have to be on the offensive. So I don't know, Emeka, do you want to add maybe one or two more solutions?
He's pretty much mentioned most of them.
Okay.
The other one I would like to just mention is the DHIS2 that is used in many countries. It's heavily funded and supported, also used heavy for a lot of decision making. No matter what anyone would think about the quality of the data, it's still being used and government is still saying this is our national tool. I mean, from, and I share the same, it needs to be strengthened. The data quality needs to be cleaned. So thank you.
Thank you. I think DHIS actually predates COVID-19. It was in existence long before. So maybe those are people who saw the future. Okay, so I'd just like us to move now to the topic of artificial intelligence. And the next question is for you, Abdulhamid. So with the current buzz in artificial intelligence, how do you think healthcare in Africa can effectively and responsibly leverage AI to drive digital innovations in public health?
Yeah, thank you, Judith, for this opportunity. And I think it's a very interesting question. Maybe a quick background for those that might not understand the concept of AI or artificial intelligence. It's simply the simulation of human intelligence in machines that are trained or programmed to think and act like human. So you have the human, then you have the machine. You train the machine to be able to do tasks that initially only humans can do, like decision making and so on. So with that background, I think we can delve into the question. And I think the most critical part of your question is that effective and responsible AI use to drive innovation, right? So that keyword responsible means we also have to address this question very responsibly. So the starting point will be the fact that Africa needs to establish a robust AI governance framework. I know I've been in support where I hear that this conversation is ongoing, but we are not there yet. So maybe currently we have to make do with individual regulations in countries, but it's good to have a collective, robust AI, responsible AI governance framework for the whole of Africa, meaning government, policymakers, CSOs, NGOs, legal experts, and all other stakeholders must come together to develop and implement policies, regulations, and frameworks that will address legal, social implications of AI. At the very least, this framework should be able to address issues of fairness, accountability, and transparency in AI systems. Then secondly, we must protect data privacy and data security, because robust data security measures are crucial, very critical for any responsible AI deployment. It means all of the providers, data handlers must collect data, process data, and store data in accordance to all of the relevant data security and privacy laws and regulations. All of these concepts that we are aware of, adequate consent, encryptions, data de-identification and re-identification, pseudonymization, what is it called, multi-party computation, differential privacy. All of these concepts must be applied appropriately and in accordance to the overarching responsible AI governance framework I talked about earlier on. So that's why it's key. So we've just addressed first part of your question, Judith. We know about the responsible AI now. I'll look at the use cases for healthcare when we talk about healthcare innovations in public practice. My favorite is usually the telemedicine. I think it's been talked about here and there today. Telemedicine, because in many parts of Africa, we lack there's shortage of quality doctors, but there's the need for quality healthcare services in many remote areas. So you can use AI-powered telemedicine platforms to provide quality healthcare services in these areas, thereby bridging the healthcare gap. Then you have also disease surveillance and early warning systems. You can run AI on public health data to predict early signs or early detection of disease patterns for disease outbreaks. Then you can respond, swing into action quickly, right? Public health experts and other stakeholders to address that problem so that the disease doesn't spread beyond that point. And thirdly on my list will be the critical healthcare commodity logistics management. We have a tool for this from eHealth Africa. That's the LOMIS. I think it's been spoken about earlier today. So with that, you can run algorithms, predictive algorithms on current or prehistoric data to detect or predict when stocks will run out. And these are critical stocks. And based on that, the system can take quick action to trigger delivery so that you don't have. And this is very important to put in context because some of these deployments are happening in hard to reach areas, very challenging areas where you don't have that luxury of being able to frequently go there to make the deliveries. So it's good to have a system, AI system that can take care of all of that for you. So that's what we do at EHA. Then you have AI-powered healthcare messages or advice like we talked about during COVID-19. We also have AI-powered self-diagnostics or self-screening tool. This one is very and immediately, instantaneously, it can tell you whether you have COVID-19, tuberculosis, and you can use it to screen many other illnesses as well, cancer and so on. So that's very powerful for certain use cases. You want to carry out tuberculosis medical outreach for 1 million people in a community. It's very expensive, right? So you can use this cheap app to screen for the 1 million people, and based on the results, you might end up having to reach only 10 or 20,000, which is more feasible, more practical, right? That's one of the uses. So there are many more. AI can help you with a personalized healthcare, personalized capacity building, but there's no time to go into all of that. But I need to take a few seconds to talk about two other important things. There is the motivation for Africa to dive strongly into AI because according to PwC, by 2030, there will be about $15 billion to the global economy. If that is not financially motivating enough, I don't know what else would be, right? Not to mention other non-monetary incentives as well that will go with AI. Then lastly, whatever we do in using AI responsibly, we must first of all ensure that we are tailoring those solutions to African peculiarities. At EHA, I think we call it African context-sensitive AI deployment. So don't just copy algorithms and copy data from the West and come and dump it in Africa. No, make sure your data is not biased against African demographics. Make sure your algorithms are not biased against the African peculiarities. And thirdly, make sure you use all of the techniques to get the best out of AI in a challenging or low resource setting like Africa. What we do at EHA, for instance, we start with the frameworks. We use very light frameworks that can work well, even in low resource or resource challenging environment like MobileNet and SqueezeNet, but there are many out there that you can use. All of the other techniques, data quantization, transfer learning, there are so many more that we might not be able to go into. So the bottom line is whatever you do, use AI. Your solution is AI context sensitive.
Thank you. And maybe just to throw a small clog in the wheel. Are we also ensuring that people are not losing jobs, or is this something we just have to live with?
That's the whole question entirely. With any disruptive technology, people will lose jobs, but then there will be opportunity for more jobs that will be created by that technology.
All right, thank you. Thank you so much. Okay, so something I picked out that will lead us to the next question is about privacy and security. So the next question is about ethical considerations when we use AI, because there are also issues around that. So this question is for Emeka. Okay, so what ethical considerations should be taken into account while utilizing technologies in public health practice?
Okay, so I'm going to follow his conversation on AI because it's an area I'm also very much interested in, especially since your opening statement started with the buzz around AI. And somebody like me go up and down. We started with blockchain sometime in 2018, 2019, 13, 14, me into it. And everybody then, the meta one was the metaverse. And then after a while, the hype cycle and it's out. So for AI, yes, there's a lot of hype around it. Even when people are just using algorithms in their platform, they will claim they are using AI because it's easier to raise funds and all of that. But let's see where, I'm going to come back to your ethics question. Where does Africa stand in all of this? Does Africa just have to copy an open source code that is doing AI and spend 100 million hours fixing the code they don't know anything about? Africa needs to build capacity. I mean, real capacity. That's the only way. And I want to differ a bit from where I was coming from, in that regulation should come first. I do think that we need to get ourselves going, doing things at large scale, and regulation will catch up. Again, I'm not saying let's not regulate, but I don't think that's if I'm given an option of regulate, don't regulate, I will probably regulate or build capacity. I will build capacity first before I'll start regulating. That's my perspective. Of course, many people, I've been working on strategic document, like my brother has said, are on the cupboards and nobody is using them. So you can understand my sentiment where it's not just about the document. Let's do stuff and get it going. So for ethics, I also follow the research that was, I'm not going to call the project. It was trying to detect a particular disease, because if I say the disease, you will probably be able to narrow down the project. It was to detect a particular disease in children, in infants. They use data from Mexico and Canada to train the system, and they are using it in Nigeria. And you can imagine the actual effect will be totally different. And it brings me back to the problem of, yes, we are talking about AI. We do need clean data to even get the result out of the AI system. So if you do not have a technology system that is collecting clean data that you can trust, even our government don't trust some of our health data. That's why we still use a lot of survey instead of our service delivery data. But that's a different conversation. So I would say ethics remains a big problem. Maybe we shouldn't overregulate. We can just pick some things like ethical guidelines that they have in Europe, just clean it a bit, make it a bit liberal, allow capacity building through doing. When we are able to build good systems, we can then, but ethics, it's a wide west in Africa right now. Everybody just does anything.
Yeah, and I think maybe that's why we need regulations, because maybe sometimes people don't even know the far-reaching consequences of some of these things. Like we talk about medical records now, no privacy. So should we really just keep that going?
I would like to respond.
Oh, please respond.
We have a lot of right now act certificate of standards that EMRs are supposed to follow, and a lot of that. How is it being enforced? How do you even know? An EMR comes to tell you they are doing this and that. You are not seeing the code. You don't have the capacity to even look. If you look at the code, can you understand what is inside? So that's why capacity is. Of course, we do need regulation, but instead of, I am a proponent of capacity that is enough to regulate.
Okay. Yeah.
Because if you throw out an app there that is not, okay. Yeah, I was just saying, practical steps we take at eHealth Africa, right, to ensure that we address ethical issues. You might not be able to address all of them, like Emeka rightly said. The applications must have inclusivity and accessibility. It should be accessible to all, physically disabled, disabled people. You need to make sure you put all of that into the design of the application, right? Then you address also cultural insensitivity. You cannot take an app now that is against the cultural norms of the people, and that would be a serious ethical issue. I can give examples of that, but probably there's not much time. Then digital divide. Is your application going to work in rural areas versus urban? Is your application going to rather enrich urban people further and increase the digital gap? All of these are ethical issues that you need to talk about. And if you're building an app that addresses business logic, you must put fair practice so that you don't put any unfair practice that will cause another ethical issues. There are a lot of things practically. So I saw Emeka did talk about regulations and all of the rest. So I just wanted to draw our mind also to practical steps that you can take to also address ethical issues. Yeah.
Okay. So maybe that's where capacity building may be important, because just like you said, if they don't even know what's happening, they just follow. But Evans, do you want to say something?
I think just to pick on the area of capacity building, I think capacity building is a term that we've used it at every point in time. And especially when it comes to system developments, skill transfer. But I come from an angle, we've reached an inflection point right now where it takes two to tango. You don't expect a developer to do a skill transfer to an M&D or a social scientist, just to be fair. So, and that is the context we are operating with even the government right now. You're finding the donors are coming. I'll give an example of DataFi, for example. We are developing applications, myriad of applications right now. And the ownership of these applications are government owned, right? But donor driven. So when it reaches for sustainability, the handover part, I'm supposed to hand over a code to somebody who does not understand the code. So then it becomes a dead stop. So I think we've reached an inflection point where when you are even engaging the government in the room, the government also now need to pull its short or its weight to really, there are a lot of skills that Nigeria has, a young talent that are out there. Bring them into the fold that they're able to have this skill transfer that is done for sustainability. It's no longer tenable for us to continue this endless loop of capacity building without being sustained. So I think that's my opinion on this.
Okay, so maybe we'll just let the jury go out on where we should stay, whether capacity building or regulation, or whether we should pick the boat. But I'd like to cycle back on something Abdulhamid said, and the next question is for you, Evans. I want us to look at the challenges now. When we have issues of copy and paste, bringing things from different contexts and just, replicating them. So why is this? Is it because maybe sometimes financial challenges? Why do people do that? So, and then that and other challenges. What are the challenges that exist, barriers to implementing some of these digital innovations?
Yeah, I think for the capacity part, I was going to bring it up, but I think that we already said that. So I'll also look at it in terms of regulatory framework. So just generally, as much as we don't talk about regulations, but having monetary and fiscal policies in place by the government to support the acceleration of ICT in a country also plays a very big role. To provide that enabling environment, it even enables consumption, adoption, and overall creation within the ecosystem. So we have, I'll give an example. The fiber optic termination costs right now, if you look at it in Nigeria, is very high. For somebody just to come and lay fiber optics for us to be able to have unlimited access to internet. Unlimited access, yeah, I think if most of you have traveled out wide. So if you have fiber optics, then we can start talking about things like having basic home internet, unlimited home internet that you can pay monthly regardless, right? But right now we cannot talk about this because the cost of fiber optic termination is too high to set that up. So the regulatory framework should also come into place where the government is willing to make concessions and subsidies in this angle, because if this is where there's, as my friend has mentioned, this the next frontier for economic growth, then invest in it now. So I think that part for that needs to come into play. As mentioned, governments need to invest in infrastructure. I'm sorry I'm on the government today. government needs to invest in infrastructure. Very well, that has noted. But also as now donors, I'll come back to now our development partners. There's multiplicity in implementation trying to solve the same thing. We have, and I'm sure if we look at it keenly, some of these systems we presented, we have good architecture that can be expanded. Actually, one system can be expanded to serve very many disease areas. But since we are also looking at the funding areas, we have to, there's a lot of duplicity, multiplicity in the same area that we are implementing. So that also presents a challenge. So how do we play that along? So there's only one unifying factor. The government, again, has to come up with a framework to manage all these resources that are coming in, to be able to really distribute to achieve the full investment of this. So I think those are the two main points. I think also for the documents that are lying on the shelves, it's high time they were dusted, updated, and actually localized. And because they provide a very brilliant framework, because they're brilliant minds who foresaw some of these things even before. So if we put these institutions of minds at play, then I think we have a lot of solutions already there. So we don't need to really think out of the box. We just throw away the box and use whatever is already available. So I think that's what I'll say. Thank you.
Okay, thank you. So you mentioned duplicity, and it just reminded me part of the reason we decided to set this up, for collaboration and to ensure that, we know what partners, we know what everyone is doing. We know what strengths we can leverage. And the next question is for you, Emeka. In talking about collaboration, how can collaborations between public health agencies, technology companies, and academic institutions drive further innovations in the field? Do you think that this sort of gathering is important, knowledge sharing, and much more?
I don't think it's an underfunded area in development that is very critical. And I mean, underfunded by non-interested parties, because sometimes interested parties do fund it and then they stifle how the conversation goes. So we cannot have enough of this because he has mentioned duplication, and it's something that remains a big challenge. But again, from my background, I know that there is no way, and I hear this a lot in public health gathering. I know there is no way you can have one system. I mean, even the NHS has smaller systems that connect to the NHS. Let's say that's the biggest one system we have in the world. So even the Estonia X Road is still connecting from multiple departments and agencies. And these are huge success stories of integration and centralized governments. I'm not talking of when you do have decentralized, where the states have autonomy of money and all that. So is it possible for it to be, will it be valuable for systems to be integrated? Yes. Should we push towards one system? It's not possible. I mean, no matter how we dream about that, it's not going to be possible because there are so many reasons why. Some are legacy systems, some solve specific health problems, some solve programs, business needs that are very, very specific. And you can't, many of millions and billions. Okay, yes, it's going to solve the problem. And how do we do this? Let's continue this conversation. These kinds of conversation, but not just at this superficial level. We should take it to the point where we bring in technical people and start looking at, okay, to connect this, looking at the actual data transactions happening in code. When we get to that level, we are closer to the answer in many cases. Thank you.
So collaborations.
Yes.
Okay.
In this part of the equation, and that's the community. I saw your question was referencing academics, government, and the rest. Yes, exactly. But usually I've seen projects that fail because all of these other elements are there, but they miss out on one of the most critical partners of the project, which is the community. I've seen a project for farmers, I think in the north, where during the design ideation phase and all of this we talk about, they looked at the core components, government, industry, academics, and all of that, but they forgot about the community. and that project failed. So it's always good to add them into the mix, whatever you're doing, right from the time they're buying. That's the issue we have with data. Even what are you going to do with their data? In as much as regulations is still not enough, I agree with him that we need to move on, but you can improvise and see how you carry them along. Let them understand what you're going to do with their data, the impact of the solution or the digital solution you are going to do for them, their own personal, what they will benefit from, carry them along. So I think it's always key to always consider the community as well.
Community, very important. The primary beneficiaries. I remember I heard a story of a community that, you know, there was an implementation there and there was a borehole and no one went there because they preferred to walk long distances to go and get the water. So we can't overemphasize the importance of carrying the community along. Okay, so at this point, I just want to open up the conversation to anyone that may have a question in the audience. Okay. Yes.
Okay, yes, my name is Fadi Pejesu. I work for Malaria Consortium. And I think most times when we have this kind of gathering, we dwell more in the technical part. And I was just discussing with a friend that in all we say, and we have this beautiful idea, there's supposed to be that discussion with the government stakeholders to ensure that there is that advocacy. And we're on the same page with all the good things we are discussing and to see how everything can fit perfectly well in government policies, plan, and budget. And we have beautiful documents, policies document and all of that, roadmap and all of that, eHealth strategy, name it, we have all of that. But even while developing that, is that mindset to say, okay, we want to track the milestones. And if we are not here, what are those things that we need to catalyze to make sure that we get to the bus stop where we aim to be? So I think in all of this, we need to also bring that on board to ensure that at the end of the day, we have results and the results are also sustainable. Thank you.
Okay, so I guess that's a comment and not a question. All right, thank you so much. Okay, there's someone here.
Thank you. My name is Tahir Buhari from eHealth Africa. So permit me, please, because I have 3 questions. I first of all love that Dr. Emeka, you questioned the whole idea of even interoperability. Do we even need it? Why? And all of that. So the first question that I have is, how can we strike a balance between ensuring interoperability of digital health tools while respecting, you know, for example, cold chain manufacturers' proprietary data and perhaps, you know, concerns around not stifling innovation, while also that balance is there. Then secondly, you talked about a trusted party or like a governance agency. What does that look like? What is the characteristics of that agency for the health sector? And what are the things that we should think about when that agency perhaps is developed? Then finally, the issue of right now, doctors to patient ratio in Nigeria is about 38 to 100,000. It's huge. We know that our healthcare workers are overburdened. So when we're talking about this interoperability piece, what does that look like at the health facility level? If I'm a health worker in a remote health facility and we're talking about interoperability, what does it mean for me? Does it mean I'm only using one EMR for all of the protocols that I have to go through? And how do we ensure these overburdened health workers, are not further overburdened by new systems? So those are my questions. Thank you.
Should I take that? Should I take that?
Yeah.
Okay, so thank you very much. Starting from the first one in terms of striking a balance, and this is something I learned the hard way. I was all an advocate of quality data, meaning patient level data at every level. because I'm the IT guy. So I was looking at that. But then I was fortunate to work with Jabi sometime 2 years ago. The biggest problem that they had was overlooking 50 countries, most the poorest countries in the world. And we looked at, they have developed a digital health strategy and we're trying to cost it. And then when we were trying to cost the cost of deploying in this 30,000 facility in Nigeria, for instance, the money is more than our budget, or maybe half of our entire budget just for health sector. Anyway, balance is to use the dirty data or the aggregate information, integrate it with necessary aggregate information, use paper where you have to use paper, integrate where you have to use use digital where you have to. And I can give you an example. You can decide that the comprehensive health facilities, the general hospital, tertiary hospital in a particular state is fully digitized. It's a good milestone. If you achieve that, while the other health posts and the rest will use paper and just refer up, and you can, the milestone, the change that can bring is huge. But of course, that's not even happening in any state, and it's not like it's going to take everything. So that's if you want. So an example is NIBS in the banking sector. NIBS is co-owned by this organization because there's no one organization, and NIBS is trusted. So they just send in their information and authenticate, and they trust that organization. In the health sector, I don't know if it's going to be an agency or if it's going to be a department in the ministry, but that organization needs to have capacity to manage this kind of, like, a certain level of IT, public health, managerial, many different capacity, few people. So I don't know, what's the last question again? Sorry? Referral is the first step, and maybe I don't know, maybe interoperability at the last mile is referral to the higher level is the greatest need. Then insurance is one that can even pay for itself. So thanks.
Okay, I think you have one last question. Was your hand up? Okay. Oh, your hand up. Okay, so 2 more and then we'll wrap it up.
Talked about one of the things I wanted to talk about government's, involvement in all of this. And I want to draw up a question from his comments. How then can we actively engage the government to buy into digital innovations? Nigeria, I'm talking about right now. We are all here. We work with government at various levels. I'm sure there are some government officials here with us. And we all have all of these experiences. Over the past 12 years, I've had opportunity of working with government in some of these digital solutions. What can we do? How can we drive this? I mean, in the past few weeks now, we saw the president of Biden has been championing the AI. He's been interested in AI. So what are we doing in Nigeria? How can we get this going? Then my second comment and maybe a question, it's about the multiplicity of digital health solutions in the country. I mean, for me, it's a concern that you see in a particular disease area, you're having multiple hundreds of digital solutions, and they are not speaking to each other. I mean, it calls for concern. I don't know. What do you say about that? Do you have an experience of that? What can you tell us? How can we bring all of this together and harness these solutions in countries? Thank you.
Do I start?
Or maybe people can share it.
And take the last. Yeah, because that's something we just discussed with Emeka a few moments ago. We were both in Kigali for the launch. It's called Africa CDC Digital Transformation Strategy early this year. So when it was launched, to address your concern, they created a repository for all solutions, digital solutions in Africa. So that's a good starting point, right? So that before you go ahead, you start thinking out of the box. That's why you said we should ignore the box entirely, right? Go through the repository. I think as of last time, there were several thousands already of digital solutions that are already in Africa. So go through that carefully. If you create a solution, only if there is no solution already addressing what you need to do. Because part of the strategy's quick takeaway was, in the next few years, there will be a aggregation of the streamlining of these applications to a few dozens, from thousands to dozens, and donors were there, funders were there, implementers, government officials were there. So part of what they all agreed was funding should only be given to applications that are going to either enhance existing applications or are entirely new only if they don't have any competing existing applications. So I think that's a good step towards your concern, because that will help to address if you don't get funds, and I'm sure people will not develop things that they will not be able to get funds. So that's a very good step that we saw in the Africa CDC digital transformation. The other government question, I think I'll leave it for my other very capable panelists to take care of that.
I can take the government question. So we've engaged government yesterday, even before coming to this meeting. I was also participating in another meeting of government, 3 departments in the Federal Ministry of Health, where we're discussing interoperability still. And we actually they had several days before they called me in. They were talking about digital health, and then I came for the interoperability part of the conversation. And there is appetite. You were in Lagos, you saw the way the permanent secretary was speaking. So there is appetite for digitization. Everybody knows digitization can help. In fact, the hospitals can attest to how it helped them save costs and a lot of things. But the government, I think the missing link is capacity within government. So I don't want to do the broad capacity building. So capacity within government to manage the policies they are rolling out, the regulations, that capacity, it's not there. And you can, and if you meet government people that have the capacity, you would love it. So I've met a lot of them as well. Thanks.
Okay, I think one last question addressed. All right, okay, so thank you so much for those questions. I think I'll just give one minute for final words before we leave.
Okay, so I think my final word is just that, basically, if you're looking at our the current dynamics in the emerging technologies that keep shifting every day, so it's high time, even as Africans, as much as we're talking about localizing, we need governments to start investing in research and development, R&D in terms of in IT. No, it's I know there's a push. Some countries only focus on research on the public health as perspective, but there needs to be concerted efforts right now for even digital hubs to be created within, and government regulative framework have to have monetary and fiscal allocation for this. If we don't have those two, then we'll always advocate year in, year out, because once government commits, then it means we are able to implement even infrastructural improvements and also drive innovation across even the younger generation as we also proceed just to incubate most of these innovations that are coming at play to support the public health intervention. So I think that will be my...
Okay, so more investment from government. Thank you. 1 minute.
Thank you. Yeah, I think I'll be done in less than a minute. Yeah, the Nigeria and Africa need to sit up. There is a report, Africa AI Readiness Index. The whole of entire sub-Saharan Africa, our score was about 20%. Average score you need is 40%. And to put that in context, countries like the United States, Singapore are on 80-something%. And about 15.7 trillion USD at stake here. So we have teeming youths that have nothing to do. They have no jobs. So this is a fantastic opportunity for the governments to come together and create an enabling environment where all of these youths can get something to do. They can get a significant chunk of that 15.7 trillion USD. I'm very concerned about that money. I don't want it to go to other continents. Yeah, so I think that's something we need to do. Then to round it up, I'll still use the phrase we talked about earlier on, responsible African context-sensitive AI deployments. Thank you.
Thank you.
Okay, so thank you very much. I would say that the data from the Global Digital Health Monitor, 70 countries, is showing that capacity building of the 7 WHO digital health enabling environment, the capacity to deploy tools, manage the tools, use the tool, is what scores least in almost all the country, 90% of the countries, and most of them are in Africa. So what that means is, I'm re-echoing your statement around, let's figure a way to build hands-on capacity within government, outside government, in a community. Thank you very much.
Thank you. So we need to build capacity for the youth empowerment, build capacity, and there's need to invest. Thank you so much for listening. Thank you so much.
Can we make a round of applause louder, bolder, stronger, and better? Great. Thank you. All right. All right, so we've come to the end of the panel session. How many of us enjoyed the conversation? Can you just give them a round of applause again from the moderator to the panelists for sharing from their wealth of insight? All right, so we're moving to the so the way this program is planned is such that it's supposed to climax. You know, it gets interesting and more interesting and more interesting. And we are going to another more interesting aspect of this meeting. We'll in presentations of different innovation from across Nigeria. All right, so the first person that will be presenting is from IMAP. He'll be presenting online, and I would like to please request all presenters that we have a timeline of 10 minutes so that we can go straight to the point, hit the nail on the head, and we can take all the innovative sessions back to back. So we're supposed to see the next presenter on the screen. Do we have him?
Yeah, I'm. Hello, can you hear me?
Oh, okay. Hello, Mithab.
Hi, nice to meet you.
Oh, nice
Hi,
to
everyone.
meet you. Can we see his? We can see. Oh, okay. Okay.
So I think the host stopped it, the video. So
could you come again, please?
The message I'm receiving: you cannot start your video because the host has stopped it.
All right, host, can you kindly help him?
Yeah, it's working now.
Awesome. All right, so I think we can all see him. Immediately after this presentation, we'll be having the EQ's presentation, followed by VDD. So I'm just going to let you know when you're coming up next. So Mitab, you have the floor, and you have 10 minutes for this presentation. Thank you.
Yeah, thank you. First of all, thank you, eHealth, for providing us an opportunity to present IMAP work in the health sector. Yeah, next. Next. Yeah, so IMAP is a not-for-profit organization that provides information management and research and analysis services to the humanitarian and development sector. So through information management, we we provide our partner on targeted assistance in the world's most vulnerable populations. Our philosophy is mostly better data, better decision, better outcome. Next. Go back a bit. Back. So in Nigeria, we have collaborations with the UN OCHA, and we built this humanitarian information analysis unit, which is partly hosted in IMAP and partly in UN OCHA, where we provide wide spectrum of information management support. So we have assessment, data analysis, GIS, meal, and data visualizations, web development, and capacity building. So the time is short, so I will be quick. Next. And then with these projects, we are reaching with, the sectors and to fill the gap of information management. Next. Next. Yeah, so we have a diverse donor across the globe, and these are some of the donors who are providing fundings for the health project particularly. Next. Yeah, and that is the area we are covering. Some of them are past projects, and some of them are the current project related to the health related programs. Next. Go back, please. Yeah, so I will give you a couple of examples which we did across the world, and then some of them is just thematically we divided into the large data set. So the large data set was for the emergency health and nutrition project in Yemen, and our donor was UNICEF, and their donor was World Bank. And then we have kind of 5 questionnaires, 3 partners were collecting this data, 7 round of data. The total data set were 105. And these partners were collecting these data in different methodologies or technologies, paper-based, COBO, custom-built technologies. And then we had a big kind of like, unstandardized data, and it needed a lot of cleaning and everything. So first, what we did, the solution, kind of like we standardize all these 5 questionnaires, bring the partners together to use the standardized questionnaires in one way. So the next time when we do the data collection, so it will have the clean data. We will not go through like months of cleaning on all these huge data set and multiple form, multiple partners. So when we did the 8 rounds of data collections, 90 to 95% of the data were clean, and then prevent and minimize the data entry error with these automations, and somehow consolidated 105 data set and generate complex analysis. And then we can see the impact of the project across the Yemen. Can you move to the next? And we can see, the output of that 105 data set. It was very difficult to present, this big data set, 105 data set to the donors, especially to World Bank, that how it worked. And for that purposes, we automated most of the work. And you can see it here that before the intervention, the map, how the map was looking like, and after the interventions, how much the services they were covering. This is particularly for CMEM, but then we can change the services. For example, 315 health facilities were not providing CMEM services, but then after the intervention, 95% were not provided. It means that from 83% services to 95% services they are now providing. So they can see, gradually the impact of the project. And down there, if you look into the timeline from 2017, which is we had the CMM services were not available. And then when you look into 2019, it was a bit slight increase, but then if you trend wise, we are looking into it, it was decreasing, but in 2019, it was increasing again. It was because of the COVID-19, but then it showed the impact of the World Bank or UNICEF intervention in the health facilities. And this is not only this, but then we have the related to availability of the services, water availability, sanitations, MSP, utilizations of the services, then coverage analysis and availability of the vaccinations. So these are the huge data set which is bringing to these 9 kind of pages, and it was very kind of showing the progress or where we have a problem that help a lot. Next. So the next the thematic area is timeliness. So how these timeliness is important in the data collections, in the visualizations and the analysis. So that was for the DRC Congo, and that was the post-mortem surveillance for Ebola virus using Aura Quick Ebola Rapid Diagnostic Test, Eastern Democratic Republic of Congo. And that was the CDC project we were implementing for them, but the stakeholder were Ministry of Health, national and international humanitarian partners. And if you look into the flow on the right side, it's a complicated flow of data or informations. Based on this, they make their decisions. Yeah, so the data was very complex, but the most importantly, they need the information in a very timely manner, so then they can make quick decisions for the quarantine or something. Let's move to the next one. And it's about like the dead body. So when the person died, the rapid diagnostic team go to the field, they take the sample RDT test and then send it to the server quickly, and then they can make decisions. Either it is Ebola affected death or it is just a normal death. If it is Ebola related death, then the consortium or the working group, they activate their alert system, and then if they do quarantine or whatever actions they have to do. But the most important here, they should to have the timely informations. The structure we organize, so on tablet they can collect the data, they will send it to the Kobo on-premises gateway, synchronize this with the Power BI services, and then present it to the donors. In the same time, we generate the alert with the Power Automate, so they can know that if there is a Ebola related death, and they can do the quick rapid action, rapid response. Next. Okay, so that theme is related to the complex data structures. So I already see one of the logistic system here, but that is also related to the logistic hub. But this is for the WHO Dubai hub, where they are distributing the medicine and equipment to the whole world, but the data structures are so complicated and they don't want to change it in the middle where the DHL was going to implement the whole logistic system. But for us, it was the requirement to bring all these data together, consolidate it, and come up with some analysis so they can make this, they can do evidence-based decisions. So, and it involved multi-level synchronizations. What we did, we harmonized the analysis, built a complex model for them based on their data transformations and normalizations. And then we did multi-level synchronizations between different apps. Next. Now it come up with the result come up with the Dubai hub is, you can see that, like, the tree in the map, it is covering almost all over the world. And that was not present in their system because the data was in the structure which they were not able to analyze in a way. That's what I was telling. It is a complex data structure. We transform that, and then they can see that, like, they are covering most of the world. At the same time, they had the criticism of, like, maybe, for example, in Yemen, they were supporting one side, but not the other side. But these visualizations are clearly showing it is regardless of, like, political influence, but then they are supporting the same time in Yemen and Aden and Sana'a. But at the same time, they can see that the trend of, like, what is more required, it was especially on the COVID time. So they can see that surgical mask in the top level, and then the girls, most of these are related to the COVID entities or COVID commodities. So in the same time, the shipment tracking was there. So which is the shipment from Dubai to all these hubs, where you can see the map and their status were updating. But for that we created their own app where they can update it, and it was a multiple level synchronization. So one database it update, and then the other one, and then it push it to the business intelligence model. Next. So in terms of the development area, where development context, we did kind of a data collection for 30 cities in Syria. And that was mostly on the damage assessment across multiple sectors, where we have a cluster asset, education, energy, government, health, marketing, municipal services, wash, security transformations. But that what built the foundations for the donors to see how better plan their targeting and monitoring interventions, and understanding how the citizens or the people, the cities are functioning or not functioning, and how the people are coping with this conflict. and that was the foundation for the donors. Next. Yeah, these are some of the visuals of that urban as project, but there are pretty much more than that. And where we can see that here in the spider chart, then the index of different services, it is working or not working. Some electricity is working, somewhere there is a safety issue, somewhere is transformation, somewhere they have the health issues, and then you can compare multiple cities too. And yeah, and down there we have the asset or damage assessment across all the cities, 30 cities, and they have we built for them a robust GIS system where they can also see by using some of their modeling techniques to see that, like the damage assessment itself, some of them were not possible by assessment, but we did based on the machine learning processes. Next. Yeah, and that is our services. Anyway, I think the project, the presentation is finished. If any questions from the participant, please.
Thank you so much for that presentation. Does anyone in the house have any question? Anyone? All right. So we don't have any question. Thank you so much for that insightful presentation. I believe that at the end of this meeting, the participants will have the opportunity to dig deeper in their private time into the details of this innovative project. All right. So the next presentation we'll be having is from the CEO of EQs. We introduced him earlier in person of Mr. Andy Ayo. Please, can we welcome him with a round of applause as he makes a 10-minute presentation.
So much. I can place it where? Okay. Thank you so much. I appreciate that. Thank you. I wish I was a guru, but I'm not. So let me not disappoint you first. My name is Andy Ayo. I'm glad to be here on behalf of the management of staff of EQs. We are excited that eHealth has invited us to share some of these, works that we have. And I think, well, you all know we're a non-for-profit in the country, registered, and we've been around for 22 years. Major core emphasis areas for us is in health, education, and also economic strengthening. So we also try the much we can to deploy tech in the work that we do. I remember recently the Conga people were very worried about the amount of i7 systems that we bought, and they were wondering, that's the vision for EQs. So we've been very, very intentional about getting high-tech computers and putting a team together that actually drives it to the next level. And we appreciate sharing this. So you could move a couple of slides. I'm not definitely going to try to introduce this. Keep going. So we all know, you could leave it there a bit. We know how much tech has actually changed the space in the country. COVID also came to help us out. And right now, I think we've moved to another level in terms of work. So I think for us, it goes beyond even work from home now and accountability issues. We need to think of how to deploy tech in having better accountability for work from home, which I think is also improved accountability of delivery and return on investment, sort of. We're getting more, but also, work-life balance for people who actually go through that. But again, accountability for the auditors. So how are we going to actually prove that you're working while you're away? These are also things, dangling in our brain while we keep going. So you see, these are familiar features. The EMR, the gurus are here. We already know where we are as a country. Keep going, sir. Thank you. So basically, I'll be just talking about 4 of the approaches. 4, we can see this is the new space now, eHealth. I didn't particularly know my audience, so I'm not sure all of this would have been there. But it still tells us the reality. That's somewhere in Osun State, but this is where we are headed, isn't it? This evening, I'll probably be having this telemedicine with my doctor in Saudi. Jabi has moved people out. So I'll be having a session about 9 p.m. I'll be having conversations and I pay for it. Last time I used him, I tell him I have to pay for the service. So because one thing we are not doing as a country is we seem to take advantage of doctors, isn't it? And we don't pay for that service, but this on the lighter note. Please keep going. I'll be talking about this with Uche. We all know ECHO. So I'll speak to this first one, which we're using across our project. So currently within the HIV space, we work with USAID in Cross River and Akwa Ibom, basically on the ECHO's 5 project, where we have barely about over 180,000 patients on treatment. So it's a fairly large pool of clients. And we deploy this online community hotspot mapping tool. It's something all of us perhaps use. I mean, something about tech, sometimes I think, so the problems, people try to solve their problems with different, and call it different names, but maybe we call this a different name. I'm sure other partners have what they call this, but it helps us to basically identify where the pool of positives are clustered. And so if you look at it, there's a geolocation, all right, that people are able to easily identify where the new positives are coming on a daily basis. So we can pick clusters of positives and identify push interventions. You know that Akwa Ibom, for instance, is saturated. Finding positives is a lot more difficult. So this tool is really helpful in sort of going over the finish line. If we're going to go over the finish line on epidemic control, then we really have to deploy technology. Recently in Osun State, this tool has equally helped us because we're rapidly scaling up in a drive in Osun State. This was previously just not a search, but we just launched the search. And I can tell between February and today, we have closing on 80% saturation. And now with fidelity, because we're deploying loads of biometrics, still technology introduction to try and ensure that there's fidelity for positives. So you're actually getting real positives. Identify key friends to our program in Akwa Ibom, Cross River, and Phase 3. I was actually looking out for Phase 3, but I didn't cite them here because I think they're also doing a work. We happen to be fortunate to use both the LAMIS Plus and the NMRS. And I think there's an NMRS conference later. I think there must be, I always say there has to be unity of all of these platforms for us to make sense of it and not have multiple platforms. So this helps us, even with recency testing. I mean, we comb and it helps us to actually identify and go all out to find the cases. And also it's cost saving because right now we're moving into an era where we have limited resources to do more. And, and if we use technology, then it will reduce our ability to spend. It will maximize our resources. So our return on investment for the resource will be higher. So we can find new positives with limited personnel. So we'll drop our case management load, which is such a huge number. We probably have over 2,300 folks in Akwa Ibom and Cross River alone going through the field, and that's not sustainable. The government themselves cannot uptake that at the end of this project, isn't it? So where do we go? Tech will come in as a big option for us to introduce and transition the management of our clients. So tools like this, one of them. So go to the next one. So we have this other one, which is quite also familiar, the evidence-driven decision-making using GIS and remote sensing. So GIS is a major mechanism. All of us are using GIS mechanism. And you could see drug pickup. We have facilities that we support between Akwa Ibom and Cross River. And we have over 2,500 drug pickups. So this tool has been extremely helpful, created to ensure that patients they can, limit transport costs because these drug pickup sites are all over. So what does the tool really help us to do? The tool allows us to see the distribution of these pickup points. So we can see them real time, like a dashboard, isn't it? And can see the pool of patients going to pick stuff there and identify opportunities for new creation of points. So we can see if there are large clusters of patients, then we think we're not really resolving the problem of their wait time or problem of their transportation. So we create additional points. And we know, just like someone said, the drone technology used by our friends Zipline, we're talking to all those are, so there has to be integration. One of the reasons why I was also excited coming here, I also conference a couple of them in the integration of efforts will be important. And it's open source now. Sometimes if you're funded by a partner, then you don't really have on total patency, isn't it? So it's open source. You can actually throw it open and then we all have a mix of it. And we should really think about it in that context to maximize donor funds. So this also helps with, letting us know, where the recent positive patients are and how we can track them. This is a very good tool. I won't spend too long of our time going over them. You can go to the third one, which is easy. Just basically strengthening our ICT. So these days you really don't have to pull patients to come to the clinic for you to carry out an ICT. So you use your phone, you call them, you can get them to go to the next facility closest to them and integrate them. And so this is making life a lot easier within our process, But there's a very new app that we're going to just talk about, which we are introducing into our program within the CDC-funded EQSP project. The SMART is like a SMART HIV app, very excellent. It's still in process. So I'll ask Dr. Oche to come talk a little bit on that and just let us in. It's a broad-based innovation that actually I think costs us to go over the finish line. We're in the process when I'm in the finish line, costs us to win the grant, isn't it? Now we need to deploy it and make it real. Dr. Che, come over quickly. Thank you.
Thank you, sir. Okay, great. So part of the innovations is setting in place. So a lot of conversation has happened this afternoon here today that builds on the possibility and the prospect of using digital technology to enhance the quality of care and the quality of service delivery. And so we looked at it beyond, please the next slide, in 2 dimensions. And beyond improving the quality of our service delivery, how do we optimize our system to also empower our clients to be able to own and make informed decisions as it relates to their own health? So we talked about the EMR and the LAMIS Plus, the EMRS platform that are all facility-based. The concept of the Smart Analytic app is to give patient clients a mobile app, just like the banking app, just the way you're able to use your banking app to make transactions, and patients can use the Smart app to make a lot of informed decision as it relates to their health. They can use it to interface and interact with their clients, the service provider. So it's an app that is being powered by artificial intelligence, which the panelists extensively about. Next slide. I'll just show us quickly a few functions of what the Speedy Smart app can do and what we are using it to do within our system. So we have the modality where patients can reschedule the appointment, where there's appointment reminder using the app, and that information goes and the conversation is ongoing. If they need to reschedule the appointment, just the way you can buy airtime from your app phone, they can just use the USSD appointment rescheduling and #671 and then make their reschedule the appointment. We can also use this to do some level of predictive analysis. There is a self-care service point within the app where patients can decide where to pick up drugs. A lot of enlightenment and education. It's also domiciled within the app. As the clinicians also were able to use this app to make informed decisions about enhancing our retention, ability to look at our clients' adherence to treatment and viral load suppression, and then make a couple of predictions. Occasionally, periodically, we do our patient satisfaction survey, and they don't need to come into the facility to have this conversation. Right from within the app, the checklist is sent, and they make a comment or two, and we get feedback. The next slide. So how does this app work? I established that the app had 2 domains, the patient app and then the web portal at the back end. So the client interact with the Smartlytics app, where they can look at their appointment scheduling, doing client service and get daily health tip amongst others. We have the AQ Central Database that is domiciled on a cloud server. And then the information on the app is synchronized to the cloud server within 24 hours. And then it is now synchronizing to the facility EMR within 48 hours. And that information becomes accessible. So both the clinician providing the services have access to the app and can interface with the client. And at the same time, the app is connected to our database within the facility system where we can look at what's happening at patient level. The key selling point for this app for us as an organization is our ability of our clients to own their health information. Contrary to the previous, your information is domiciled in the patient's folder, the information is domiciled in the EMR, but at this point, they're able to access their information, they're able to have conversation without necessarily coming to the facility. If for any reason they may need to reschedule their appointment, they're able to do just that. As we wrap up this conversation because of time, the next slide, we also like to establish that we are mindful of data security and privacy. As we talked about digital technology and digital innovation, one key cross-cutting issue that we need to clearly address is the issue of data security and privacy. So right within this app, there are features, inbuilt features like all other mobile apps to ensure that there are certain degrees of security and privacy, such as the screen lock, the password lock, the fingerprint lock to secure app content. The app also has the capacity to log out within when not in use, and then you need to come and resign so that the content are protected. All the clinicians that have access to this app also have signed to a data privacy and a data management policy before they are being enrolled into this app. So as an organization, we are mindful of what is evolving. We are mindful of emerging reality. And one of the solutions to the emerging reality in the public health space is the uptake of digital technology. Digital technology has been demonstrated to us that it has capacity to improve the quality of care, not just for the service providers, but also for the clients on care and treatment. And we'll wrap up this conversation at this point. Thank you very much.
Thank you.
All right, please, another round of applause for these powerful speakers. All right, so please, if you have questions, kindly note them down for whoever you want to direct your questions to. So at the end of these presentations, then we can take a couple of questions and engage in stimulating conversations around these presentations. I'm rhyming too much, sorry. Okay, so the next presentation, I'll be inviting Mr. Ifeanyi from Jabi. Can you please give him a round of applause? Yeah, you can use this.
Yeah, good afternoon, everyone. I think it's afternoon. My name is Ifeanyi from Jabi on the RISE project. I'm just going to do a brief presentation on what we've titled Enhancing HIV Patient Care through Predictive Analysis in a client management application. I think everyone has spoken a lot about artificial intelligence. I mean, the panelists and the likes. I want to thank Mr. Ayo and David. They've made some presentation around app that has to do with clients management. However, this app was born out of a necessity for something which Dr. Ayo mentioned. One of the things that we are doing with the app is things around the area of accountability. As a result of the COVID as well, a couple of things came up and clients need to still be managed. Please, next slide. Let me just introduce the RISE project. So the RISE project, Reaching Impact, Saturation, and Epidemic Control. It's a 5-year award by USAID, focusing on HIV testing, counseling services, care and treatment, viral load services, M&E, and health system strengthening in general. So a background to the application. Last 2 years, 2019, 2020, COVID broke out, and from data that we have gathered in our program, we discovered that it really affected a lot of clients in terms of the management of their care and all that. So we started thinking around how we can get these clients to still access their care and while maintaining the quality of care that is provided to them. Earlier on, when we started the project in 2019, we had adopted a case management approach. So for those of us who might not be privy or might not have the knowledge of that, a case management approach is just where a cluster or a group of clients is kind of assigned to someone to provide care, or put it like that, provide care to them. Ideally, there was no standard, there was no procedure, there was no guidelines on how this was carried out. But we had sat down and we started thinking around something, and we came up with an app that we can put in the hand of the case managers to be able to manage their clients properly, as well as reports to the donor or to us, the IP, and we in turn report to the donor on the level of activities or the kind of care they have been providing. The organization has spent a lot of money in hiring case managers. It has spent a lot of money in making sure that they are paid and all that. But over the time, we have found out that the accountability is not there. A couple of things. So someone might not deliver on their jobs and all that, and they will still, will still have to spend and spend and spend. Please, next slide. So why did we come up with the solution? One was client inclusion. They mentioned something about machine learning and predictive analysis, which we discovered from clients falling out in care. But this machine learning and predictive analysis actually was, the product or the output of it was learned with data from our system. During the panelists, I think the eHealth director mentioned around, is it, oh, I think it's Mr. Emeka, around the disease that was trying to be tracked, but the data for the machine learning or for the algorithm was from Mexico or something. But what we try to do here is we pick the data from the longitudinal data we had gathered around our systems. This was not part of the app. It was a standalone project, but we had to include the outcome into the app. We also have GIS incorporated to track the epidemic. So we do hotspot mapping and clustering to be able to identify index cases and to be able to identify where the clients that are under our care are moving to. Then also, as I mentioned again, things around accountability and visibility of work. We wanted to track the accountability of the case managers. We wanted to make sure that they are accountable. So within it is an accountability framework that tracks and that finds out or gets to give us information on the activities the case managers are carrying out, as well as the visibility of case management efforts and our case management diary. So we try to personalize the thing. Usually we had a manual library, a manual diary where case managers have to write down, their interactions with each client. So for example, a case manager is moving on in life. The next person taking on the client's management will not have a lot of work to do in terms of understanding this client's pattern of behavior before they even try to provide service to the clients. So we also try to include that as part of the thoughts around why we were coming up with the application. Please, next slide. Yeah, so the key functionalities, just a few functionalities, appointment monitoring, obviously, reminder system, index contact, as I spoke about, client tracking, viral load monitoring, medication adherence assessments, our multi-month dispensing, so you can dispense drugs up to 6 months. It's called MMD6, up to 6 months, but you have to check on the clients at intervals. The real-time predictive analysis that I spoke about, and then the adherence counseling for the clients to ensure that they keep taking their drugs and they are also virus suppressed as well as active. This next slide. So, I mean, the features is role-based. One of the things we considered when developing the app was security. Was our main focus, and data confidentiality. So we discovered that most of the electronic medical record systems we have, unfortunately for us, some of our data are not encrypted at rest. Some data, those are some of the findings we had. But for the system we had, we make sure that the data is encrypted at rest. So even from the database level, the data is encrypted up to the app. So you can't see client identifiers, you can't see patient names, you can't see anybody. If someone takes the app and even mistakenly gets their way into it, they won't get to see client names or anything, except the case managers, except they let out their pins. So we also had to create pins, just like your mobile phone for banking apps, created pins. So before you can see clients' information, I mean, you need to enter another level of security, another level of authentication before you can see that. Multi-platform compatibility, that's for iOS and Android. Security, as I've spoken, third-party integration. So the app is standalone, it works offline, it works online, but it integrates with EMR. It's EMR agnostic. So any EMR, Lamis Plus, OpenMRS, or any other EMR that comes on board, it has capability to integrate. Documentation, I mean, I mentioned offline capability and robust form design factor. Please, next slide. So this is just the how it interface looks like. The app is to be piloted in 40 facilities starting from this August. This next month is going to be piloted in Kwara, in Taraba, and then we'll scale up from there. Having the training next month as well. So this slide just shows the screens of the app. So if you just press your next button, you can just see. So if you look at the third screen, for those who can see clearly, you will see where personal details are more like masked. So the addresses are masked, the names are masked, and every personal identifiable information is masked. So the app is safe in even anybody's hands, but you must have those levels of security. And for the database access as well, there is no information on the database. They are all also decrypted. They are encrypted at rest and also decrypted when they are being loaded into the application. Next slide. I think this is just the high level architecture. We didn't go deep because we realized that time might be of the essence. Please, next slide. So we divided it in phases. Phase 1 we started in 2022, as I mentioned. We've done phase 1, phase 2. Phase 3, we are currently integrating the machine learning and we are rolling out as well. Then phase 4 will integrate the GIS, as I mentioned, as we've seen in the outline earlier on this slide. So these are the 4 phases we are going through. And currently we are in phase 3, which is July 2023. And as I said, we are piloting it in August as well. And we'll proceed from there. Next slide. Thank you. I think that will be, I don't know if I'm on time, but that will be all for me.
Thank you very much for that timely presentation. All right, so I hope we are noting our questions and maybe a few recommendations also too. Also, maybe if there are very important gaps that you also want to bring our attention to, please kindly note all of this down. At the end of the presentation, we will take them. All right, so we'll be taking another innovative presentation from pharmacist Murtala Bello, Sokoto PhD, vaccine direct delivery. Please kindly give him a round of applause as he comes up here too.
Thank you very much. I think he has already mentioned my name, so there's no need for me to introduce myself. So we will be looking at the vaccine direct delivery in Sokoto State, which is currently thank you very much. By way of giving some background information, we are aware that Nigeria contributes to the global number of unimmunized children in the world, and government has been making efforts to strengthen routine immunization coverage, and that's to reduce the under 5 mortality. And this is largely due to stockouts of vaccines, life-saving vaccines in our health facilities. Because of that, vaccine distribution has been largely made efficient using third-party logistic companies or partners. Because in those days, governments used to distribute these vaccines, but because of the different lapses here and there, these vaccines are not always available for use in our health facilities. And that is the reason why outsourcing deliveries has become really very important. And then, some of the issues that are being faced by the states, as I said, is weak visibility into the last mile stocks, because when government was doing it, we don't have that visibility due to unreliable data available for vaccine forecast and consumption record. Of course, that will lead to inadequate stock data for calculating also wastage rates. And then, of course, we have stock out of antigens. Next slide, please. So this is just a graphical representation of the supply chain architecture of Nigeria's vaccine supply chain. We know we have the National Strategic Cold Store that feeds the zonal cold stores on quarterly basis, and the vaccines are pushed from the zonal cold stores to the stores on quarterly basis. And then, of course, stores now push these vaccines to the LGA stores and facilities on monthly basis, while these that are receiving this stock usually feeds the casket facilities on weekly basis based on their routines for their immunization sessions. Next slide, please. So this is just a background of Sokoto State with some key information. Sokoto has 23 LGAs and 244 political wards. It has over 800 health facilities, but currently over 500 are providing routine immunization services. Of course, you can see the cycle of delivery, which was done bi-weekly. That's every 2 weeks between the year of 2017 and 2020, but now it's been done monthly from 2020 to date. And that is being achieved using about 6 operational vehicles and about 5 drivers. You can see the geographical spread of the facilities that are offering the routine immunization services in Sokoto State. Next slide, please. So this is the Sokoto State push model. As we receive the vaccines from the zonal stores, as I mentioned, to the state cold store, that also is moved to the LGA store, and then from the LGA store to the Apex facilities, and then to the casket facilities. In this delivery, we use what we call the Lomis Deliver, which is the software that the eHealth is using, which provides real-time update on the quantity of stocks of vaccines delivered to the LGA cold store and, of course, to the Apex health facility. The LGA cold store usually holds just the buffer stock, so that when the Apex facilities run out of stock, it's very easy for them to access replenishment from the LGA than having to come to the state. Of course, also equipped primary health facilities, they also push vaccines to the unequipped cascade facilities that use the normal cold boxes or other vaccine carriers to collect their commodities, vaccines from the Apex facilities for their activities. Next slide, please. So, as I've mentioned, eHealth Africa was selected by the State Primary Healthcare Development Agency as the preferred third-party logistic provider, based on, of course, the experience and the technical and operational capabilities and the mix of digital tools supporting the program. This was executed with Sokoto State Primary Health Care Development Agency, delivery of vaccine and drugs to what level health facilities and LGA cold stores with equipped functional cold chain equipment in an effort to adopt the MPA-CDA push strategy. Next slide, please. So the objectives of the whole exercise is to distribute vaccines to the equipped health facilities across the state, and also to ensure that no damage to these vaccines during the course of transportation. Of course, also the temperature of storage of 2 to 8 degrees is well maintained through the transit time up to the time that the commodities reach the facility and then they are back to the state cold store. Of course, one of the objectives also is to retrieve delivery data for each health facility on stock levels, vaccine consumption, vaccine wastage, and the state of the cold chain equipment, whether it is functional or not functional at each health facility during delivery. So the officers that are making the deliveries, they don't just make the deliveries, they take stock of what is available in the facility, which is fed into the Lomis deliver, and the software informs them of the quantities that they need to deliver to the health facility to take them to their max level. When they do that, they also get information about the functionality of the cold chain equipment at each health facility. We also use this to build the capacity of the primary health care board officials and healthcare providers at the service delivery points. Additionally, also, the objective is also to collect immunization waste, such as sharp and empty vials from the cold chain equipped facilities after every vaccine delivery and transport to the state cold store for appropriate disposal. So part of the objective is also to have a reverse logistics for the immunization. So this is just a pictorial representation of vaccine direct delivery. The Sokoto SPSCDA engaged, we have mentioned this before, and then you can see that there's a delivery officer there taking stock of the vaccine stock in the health facility from the cold chain equipment. And this has been operational since December 2016 with 241 cold chain equipment health facilities scheduled for deliveries. Next slide. So this is the process of the vaccine delivery. At the first instance, eHealth is informed 36 hours before the beginning of the delivery of the distribution of the vaccines, of the readiness of the stock to be moved to the health facilities. Then, of course, immediately that starts, there's daily picking and packing of the vaccines into the cool boxes that will be transported using well-equipped vehicles and well-equipped and temperature monitored boxes to the health facilities. And when that is done, the delivery in itself is done by the eHealth office who moved one to the other to make the deliveries. Of course, there also be information on field and cancelled attempts, especially in places where maybe the officers go to deliver vaccines and for some reason or the other, they are not able to deliver the vaccines. So such information is also captured and transmitted. Of course, there is continuous temperature control and monitoring throughout the process of the delivery. Next slide, please. So these are the digital tools that are used for the delivery of the vaccine. We have the Lomis Deliver, which I've mentioned is used, to take stock of the vaccine count at the health facility, and then information is fed into the software, which informs the quantity to be given to the health facilities during that visit. And then we have the Varo application that is used to determine the quantity of the cold chain equipment at the health facility, so that at all times the state is aware of the number of functional cold chain equipments that we have and the non-functional cold chain equipments that we have. Because if the equipments are not functional, then the state will save costs by not having to make delivery into that health facility until the functionality of the cold chain equipment is restored. We have also the Pogo LT, which now creates a dashboard on the functionality of these equipments when the barrel application is used to check the functionality of the cold chain equipment. In all, we have a Google dashboard where information on all these processes can be accessed by stakeholders. What we have there, we have the log tags. The log tags are used during the transportation of the monitor real-time temperature of the environment where the vaccine is being carried. So we have also the fridge tag that is used to monitor the functionality of the cold chain equipment at the health facility when delivery is being made. Next slide, please. We have here a pictorial representation of one of the eHealth staff making delivery at the health facility in Lopa PHC in Sokoto State. And then below, we also have another instance where the delivery officer is taking a record of the cold chain equipment functionality performance before delivery of vaccines at Arkile PHC in Sokoto. So as I said, they have to monitor the functionality of the cold chain equipment because before such vaccines are being delivered to the health facility. Next slide. So this is a record of the achievement since the time when the delivery started. The total antigens delivered so far up to June from 2016 December to June 2023. A total of over 21 million antigens were delivered. Total dry goods delivered were about 23.6 million, and total children immunized from that is about 8.4 million. Our total successful delivery about 27,837 successful deliveries. And then, of course, reduced stock out rate to about 11% as at June 2023. With the integration of the Lomis Deliver, you can see the improvement in the stock out rate from 2017 to 2021, from a stock out rate of 61% to 8% in 2021. And that is really a very big achievement. Next slide. Of course, also because of the innovation that is monitoring the functionality of the cold chain equipment, we have an increase in the equipment, cold chain equipment uptime from 91 to 95% just between Q2 of 2022 to Q1 of 2023. Next slide, please. Thank you very much for your attention.
Thank you so much, sir. All right. Which is very soon. All right, so we're going to have another presentation from Japago on the use of electronic platforms to increase access to HIV ST in the private sector through online voucher distribution. That seems to be an interesting topic. All right, so please, with a warm round of applause, let us receive Chidima Umebido. I hope I pronounced that right, from Japago.
So HIV self-testing in Africa is an extension of a multi-country HIV self-testing award funded by Unit A through PSI. We commenced with HIV self-testing, and then we expanded into hepatitis C self-testing. So all that is going on through Japago in Nigeria, where Japago is a lead partner. So our core objective, just a backstory, our core objective is we were creating an enabling environment for the sustainability of self-testing, which will lead to self-care in the next couple of years in Nigeria. We support the Federal Ministry of Health through in collaboration with other partners to introduce innovative HIV/ST service delivery points. And in all of these, we continue to generate evidence in for decision making to champion the causes of some of these innovative strategies. So in all of this, how increase TS for HIV self-testing. And we found out that working with community-based organization would be one of the key ways of expanding this access, especially because at the end of the day, HIV self-testing, we want it to be in the private sector and not just in the public sector. So we had to engage with CBOs and the community pharmacists to be able to push out those products out there for the end users. So for HIV self-testing, we have like 4 main distribution models, which is the facility, the key population, OSS model, the community, and the private sector. So for I'm going to be talking about the collaboration between the community and the private sector model in the presentation. So for the private sector model, we had to work with community pharmacists who would sell the test kits to the end user. So we start with then we subsidizing it. That's where we start stimulating investment from the community pharmacists to procure the test kits and be able to get end users to buy this kit. There has to be like a lot of demand creation, a lot of awareness creation at different using through different channels, just to make sure that the product is out there, considering that HIV self-testing is still competing with in the private sector, is still competing with the ones in the public sectors through donor funding and all of those. So we needed to do all those engagements with both community pharmacies and CBOs to support that. So we had an innovation called the demand side financing. So the demand side financing basically, and what it means is that we work with a group of community pharmacists. We support them create demand for HIV self-testing. Clients come to the facility, come to the pharmacy, and then they pick up the test kit at a reasonable charge. We start with 500 naira, and now at 1,000 naira per test kit. So so for them to do all of that, we had to work with a CBO called Anaid. They work with young people in Lagos, so they had to cover Lagos, Akwa Ibom, and Rivers and FCT for this intervention. So these are some of the strategies that we employed. We had to do a lot of engagement with regulatory bodies, the local manufacturers and distributors of HIV self-testing. We started with initial free distribution of kits, and then we started doing graduated cost transfer and markup for the private sector. We know the private sector, they have to be able to invest in a product, they have to have like make some money out of the products that they are selling. So we got like 5,000 Mylan HIV tests for this intervention. We buy one, get 3 free model for the community pharmacists when they buy any test kits. So through the multiple entry points, so we had clients who would come in working through the pharmacy. We had the online funnels, and we have community mobilization with community teams and the facilities actively mobilizing people, telling them about self-testing and where they can get it and all of that. And all of this thing, we try to maintain the issue of pricing for HIV self-testing. Next slide, please. So next slide is just going to show like a very simple framework, because we're working with a CBO, where the core aim was just to increase the online demand for HIV self-testing. It was for a period of 2 months, and increase awareness and increase uptake, and then also through the demand side financing, drive sales for the community pharmacists. So we came up with social media campaigns, and then we also like social media campaigns on different social media platforms, Facebook, WhatsApp, Instagram, and all of that. Then clients want them go through those channels and then fill like a form online, and that form, they get a code. When they get the code, they use that code to go to one of the pharmacists that we are partnering with for the demand side financing to redeem it for a self-test kit and for a price. And then later we have people at the back end who collates all the data, and the system generates the data, and then we use that to inform program decision. Next slide. So this is just like what the user journey looks like. We have the campaign that we start with. When we do the campaign on Facebook, WhatsApp, Instagram, TikTok, whatsoever, and we did this with NASCAP and NACA, just to make sure that we have all the buying necessary. And then we have the campaigns telling them how much they will pay, when it was going to expire, the payments, when it will expire, because we did it at different phases. The free phase lasted for like 2 or 3 weeks. And then the paid phase the paid phase is still on anyways. So we still with 500 naira. So the 500 naira lasted for 6 weeks. So once the client indicates interest, a form pops up on, he gets a form, like something like a Google form, where he gets like, either he does his self-risk assessment if he wants to, and then he also fills a voucher. So once he fills a voucher, a code is immediately assigned to him. And once that code is assigned to him, that code is, he also gives him a list of all the pharmacies in his region where Japigo is partnering with. He takes that voucher and goes to the pharmacy and then gets his self-test kits at a price. And then he comes back and he continues to engage with people at the back and to report his results. And then if he's reactive, we try to link them to the nearest pharmacist using the National Referral Directory. So this is just an overview of what the user journey looks like. And then we update the respective donor-funded registers and all of those things. But the journey happens online, and the CBOs are the one in charge of this. They're the one championing this. We have a lot of young people who are at the back end tracking it and trying to make sure that they have an interactive demand creation and all of those for the end users. So this just like a list of some of the achievements in 2 months. So through that platform of the voucher distribution and redemption at the community pharmacies, we're able to reach like over 444 people. So depending on the age disaggregation, from 30 to 34 to above, we reach a lot more men than women. And 444 vouchers were given out through the online platform. 428 people actually went to the pharmacist to get a self-test kit, and 414 people reported their HIV self-testing result. So which was quite impressive, considering that self-testing, people felt like they won't be able to report their result because of it's self-test. I'll just do my result and I just do my test and nobody needs to know my result. So it was kind of like interesting to see that. It was a short intervention, more like a pilot to see how it would be. But gradually, we now scaled up to the private sector, where the community pharmacies are in charge of all of these user journey and all of the products. So I think that's the end of my presentation.
Hello. All right. Thank you very much for that presentation. Again, like I said, and it bears repetition, please have your questions on hand. We're going to have a virtual presentation from Dr. Lawal Bakari. Dr. Lawal, can you hear me?
Yes, I can. Yes, good afternoon.
All right, good afternoon, Dr. Lawal. So SafeTT is the innovative idea he will be presenting. Once he comes live, we will be able to get more details of that innovative solution.
Am I supposed to come on video also, or audio is just fine?
Yes, you will come on video once we are ready to share your slides.
Okay.
So just give us a minute. Just give us a minute, please. Right. Dr. Lawal, can you share your screen, please?
Okay. Sharing my screen.
All right.
One.
All right. Thank you. So you have the floor.
Thank you very much. our focus is to solve one of the key challenges in global health at the moment, which is looking at all things international health regulations related to travel and health security and related things. Now, our simple promise to the people that we are serving is that we want them to enjoy, think of safety, and you will see the reason why we decided to go in this direction. So the first thing we realize is that the main problem in this space that probably is perpetuating the challenge is that travelers naturally downplay travel safety until they are exposed to travel risk and insecurity events. Usually, this ends up costing us things like COVID-19 pandemic, because when you go to a typical airport, you will hear passengers saying things like, I would rather just buy a yellow card. That I would rather buy a yellow card than test for yellow than get vaccinated for yellow fever. Now, this is part of the many behaviors that are out there by the consumers. So typically, when they downplay the safety conditions that surround their travel, it ends up costing even the travelers more when they are now exposed to those situations. So what we know is that managing health security concerns for those on the go can be really hard. The first is that people are too excited about travel to think about COVID tests, yellow fever vaccination, or any form of stress that we might think in global health that they face. And this is because, number one. Number two, this communication exercise itself is complicated to the point where sometimes we have issues with people even making sense of some of the things that we are saying. And then finally, when these things happen, they become compounding problems for lives and livelihood, even beyond those who are exposed to those risks. So on our side, what we are trying to do is to change the method from the regulatory-centered approach to the consumer-centered approach. That instead of government just telling us everything that we need to do, can we motivate consumers to make sense of what needs to happen and begin to generate better behaviors and maybe better compliance and basically eventually outcomes for the global health space. So what we are doing is we are blending safety into essential consumer value, particularly when people travel. So things that people are excited about when they travel are things like deals. They want to travel with convenience. They are looking for like better products and services that can serve that travel. And then we're also building a supply chain to deliver on that great consumer experience that we paint for people when they are on the go. So we feel with that, consumer will begin to make sense of the value they want to derive as opposed to just complying with the government regulation out there. So this allows us to literally say to people that, look, we want you to enjoy your trip first and then think about safety next. So why did we go in this route? We've done a lot of studies. And one of the things we realized is for us to solve this problem, first, we must look beyond health security to solve health security problems. We cannot continue to isolate health security in the broader consumer challenge of security and travel. That's one of the key things we found out. This is based on a study we conducted with a university in the United States. Second is that we need to collaborate deeply in the travel sector for us to accomplish this. It's not enough for countries to throw out regulation with that. The collaboration has always been largely in public sector and a bit of private sector compliance concerns. They put command on them. If they don't comply, we put penalties. And then we discovered that largely this has to be a mobile setup. So what are the safety concerns that we realize that we are solving and therefore we are currently solving now? We discovered that for us to make this exciting for consumers, there are like 20 concerns in safety. And based on that, we're able to provide like the sort of services around those things with health security embedded within. So what does this mean generally? We have a two-pronged product. We have a SaaS product, which is like a software as a service, particularly for corporate organizations that have people on the go. And then we also have a mobile application that is on the Play Store and also on the iOS the Apple Store. What this application does for individuals is you can use it to plan your trip to wherever you are going in the world. It tells you the safety situation around these 20 domains real time, and it tells you how you're able to protect yourself with products and services that are relevant to those conditions wherever you are going to, kind of provide convenience. And then we provide additional layer of better pricing, competitive pricing to the other people who are providing those things to kind of create that kind of consumer behavior shifting and value. On the other hand, we also have a supply chain concern, part of what of kind of those things that happen when we have these threats and demand surges. So basically, we are preparing providers of hotels, of airlines, of travel safety kits, of filter systems where water is bad, to stores who are stocking things like sanitizers that we saw in outbreaks that usually go out of stock during outbreaks, among others, to help them to be able to stock in time based on the pattern of threats in preparation for demand that might happen. Our solution uses a mix of big data and decision algorithm to kind of power the huge global need for that global information status, and also tailoring the advisory to the current situation and also the marketplace opportunities to those situations. So when it is raining, you buy umbrella, right? Those are the kind of things we are offering. When it is very cold, we offer you winter jacket or sweaters. Where there's an outbreak, we offer you prevention like universal safety kits or vaccination services in a local hospital or in public hospitals, as the case may be. We also provide information from public sector because information becomes a service in those situations. Can we get likes of NCDC to put that information way ahead so that based on when people get to those places, they find the government regulation based on that place so that they don't get to the airport, they get turned back and everybody keeps pushing back. Those are the things that we do. So it's a mobile application. If you go to safety.com, you'll be able to find some of this information there. We are kind of providing like an Airbnb approach to solving this problem. That is from the supplier side, and the TripAdvisor approach, but primarily for safety. So you can download the application and then use it. If you go to our website, you'll be able to find more information on it. So basically, this is what we are. We are based in the US and Nigeria. We are very happy to be here. And this is basically what we do. Thank you very much.
Thank you very much, Dr. Lawal Bakari, for that presentation. We're going to have one more presentation, after which we will now take questions from the audience. Okay, so let's take questions. So the questions will cut across all the presentations that we've had so far, innovative presentations that we've had so far. So if you have a question, could you please signify by raising up your hands? All right. Please kindly state your name and your organization. Thank you.
Hey, good afternoon. My name is Osaso Wens from Action in Nigeria. This question is for the HIV test kits, Jabi. I want to know what kind of deliberate partnerships are you engaging in making these test kits available for community people? We know they have a variety of issues that they need to attend to, and assessing the kits for 1,000 naira proves to be quite difficult. We know several cannot even afford to send their children to school or pay simple PTA fees for as low as 200 naira. So what deliberate partnerships are you engaging in?
Okay, thank you very much. Let me speak on our behalf. So as she mentioned, Jabi partners with the community-based organizations, the CBOs, first of all, and the approach is also to make it a public-private partnership in terms of having the costs not fully borne by the locals or community members who are accessing the test kits. So they get to pay like a percentage, and then the other percentage is taken care of. But I'll let her like flesh it out. She's the one more vast in that area.
So the whole idea of self-testing in Nigeria is that NASCAP has adopted the total market approach for HIV self-testing. So what it means is that we have different categories of people. The free people that can get the test kit for free. We have people that are subsidized. Then we have the fully commercialized people. So in that way, depending on where you belong, you should be able to have access to the self-test kit. So, but to have the self-test kits, it means that community pharmacies need to stock them. And for them to stock it, they need to get it at an affordable price and know that at the end of the day, there's a markup for them that they can get. So partner with community CBOs and community pharmacists is the whole idea, so that the community-based organization, they will start with the free one because they know where the free people who cannot afford the self-test kits are, and they also know where people who can afford that 500 naira to 1,000 where they are. So the whole process, and then because of we got like donation free test kits from Mylan Vouchers about 75,000. We're able to like tell the community pharmacists, as long as you buy a self-test kit, if you buy one, we'll give you 3. So in that way, we're helping you bear the burden till the demand is out there for self-testing. So I think that's the whole idea of the demand side financing. But at the end of the day, the way the condom went in the country, that's the same way we want the self-test kits to go. Just to make sure that everybody knows that I can walk into a pharmacy and I can buy it, basically.
All right. Thank you very much. Okay. Is there any other questions? Someone else? Okay, great. Question. Please, your name and your organization.
Okay, yeah. So, Usman Lar Way is my name. I represent and did tracker. So, my question goes to Chidima from Japaigo. So, my question is this: you made mention of people that report their cases after testing. So, what happened to people that do not? So, and then, that's the first question. So, the second question is for people that do report their results. How are you measures? What are the measures for them to actually protect what's their results? Thank you.
Okay, so the first thing for self-testing is that we're trying to empower clients that, okay, you can use the self-test kit, and you also have the power to decide what you want to do next after you've tested yourself. Do you understand? So most times in other countries, they recorded like a reporting rate like 50%, 60%, 40%. But in Nigeria, we record, I think because of a lot of PEPFAR work that has been done, all the work done by implementing partners. So a lot of people already have an idea of what HIV is. So it's no more like the stigma is there, but it's not like before. So people are able to freely report their test. Once they do their test and they are happy about it, especially people who are non-reactive anyways, they are very eager to report their results, you understand? So I did it myself when I do my results. So that helps. And in terms of the data privacy, when they report, so adhering to what we have in country in terms of reporting of data and all of that, the tools that are there at the back end, we have trained, what they call them, DEX officers at the back end who collate this result, and those shared privacy that we usually do and shared confidentiality that applies in the facility also applies in the private sector and also in the community. So something simple like that.
All right. Thank you very much. Is there any other question? Okay, we have one more. I hope it's not for Japaigo again.
My name is Cecilia. I represent FHI CTC. My question is for you too. Sorry. I just wanted to speak about referral. So someone tests positive, reports his or her results, and then the person is referred to a facility. Is there some kind of follow-up to make sure that the person got there, received treatments, and is retained in care, or this process just stops at test yourself, go to a facility, and from there someone else takes over?
Okay, thank you. So the pharmacies we work with in the different states, they all have lists of implementing partners and the referral coordinators of those partners in those states. So once the referral is done by the CBO to the pharmacy already has that directory that, okay, you're supposed to go to this facility. And we went a step further to ensure that the pharmacy has the implementing partners, contact person in those facilities. So that person now takes over from there. And most times the client actually come back to report to the pharmacy or the CBO that, oh, I've gone to the facility, I'm confirmed positive and I've started drugs. So that's 360 referral mechanism exists, true, but it has to do a lot with the collaborative efforts we put with implementing partners and the.
Thank you, Chidima, for repeatedly taking the bullets. Well, it doesn't look like this is the last one. I'll be praying for you.
Try to take away the heat from Chidima, please.
Thank you so much. A gentleman indeed.
Okay, so I just want to go back to the issue of, vaccines and safeguarding the integrity of vaccines. And this goes to the presentation that we made with Sokoto State. I know that some of so some of the feedback that we've already got today is that government needs to do more. Government needs to do more. But I really want to give credit to Sokoto State, who we have been working with since 2017, for having an open door policy when it comes to even testing out some of these new digital tools. So while of course our policies are not there, and we have a lot of them in the proverbial cupboard, I think there are certain government agencies that have really shown an openness to try new digital tools to really see how can these, continue supporting, the immunization supply chains. So for Sokoto State specifically, because I've been working since 2019, when we rolled out that application, we have collected over 8,000 whole chain performance data reports. So that in itself is a huge impact, right? So I think we need to give credit to the government. We know that they need to do more, but I also just want to make this point that, we have seen, examples of where government has been open, and we need to also, highlight that. Thank you.
All right. Thank you for that note of commendation. All right. That's great. Please, your name and your organization. Thank you.
Okay, my name is Samuel Aliu, and my question goes to pharmacist Murtala Bello. Yeah, so thank you very much for your presentation and for sharing with us your experiences using the LOMIS app to provide last mile visibility to vaccine stocks in the state. My question will be, how is this intervention influencing decision making in terms of reaching targeted populations with vaccines in the state?
Okay, thank you very much for your question. You know that at the State Primary Healthcare Development Agency, as we are implementing the primary healthcare under one roof, we have the different subcommittees that have been put to be in charge of various aspects of routine immunization. And so we have the State Logistic Working Group, who are majorly the committee that manages the issue of vaccine supply chain. And they are the ones that work really closely with the eHealth Africa in the delivery of these vaccines. Now, I've mentioned some of the milestones that have been achieved during this partnership, but then again, we have a higher committee, that's the State PAC Implementing Committee, that we provide information with, who are the real people that are concerned more or less with taking most of the decision in relation to improving our immunization status of the children in Sokoto State. And as you can see from the improvements in the delivery of the vaccines and availability, you can see that if you look at it from even though the data is not shown there, there has been some level of improvement in the immunization coverage of children that are visiting our health facilities, unlike before when we're having lots of stock outs of commodities in our health facilities. So these are some of the ways from the data that is being generated, the Primary Healthcare Development Agency management takes certain decisions, that improves the health outcomes of people accessing immunization. Thank you.
Permit me to make how some of this data is being used when we shared with the SLWG. So as you know, right now, Sokoto State is having a monthly vaccine delivery to about 350 health facilities. So not only are we delivering vaccines, but we are also collecting data about the performance of the cold chain in that health facility. And then at the end of the delivery round, there's an aggregation that is done for all of the cold chain performance data that has been collected. And that snapshot report is then shared with the SLWG in terms of the status of those cold chains. So some of the decisions, example that have been taken at that SLWG is, for example, for the cold chains that are not performing according to spec, those that have maybe performance anomalies, the SLWG will right then and there initiate the resources that are required to fix those fridges, right? So that is ensuring your cold chain saturation rate is, at the level that it needs to be across the state. Then the issue of equity. If you don't have vaccines available in those communities, obviously the issue of equity is not going to be addressed, right? So this is how all of this information and all of this data that is being collected is being shared with the right people at the right forums so that those decisions that you're talking about can really be addressed.
Okay, thank you. So just another question for you. Does all the health facilities in Sokoto State have cold chain equipment?
No.
So how do you resolve issues around, missing data and all that?
So, right now, Nigeria has a policy. I think the goal for the country is one functional PHC per ward. I think most of us here will be familiar with that. So the goal is to make sure at the very least, there's one primary healthcare facility that is cold chain equipped. And then that primary health care facility will become what we call the apex facility. And then it will supply vaccines to other facilities around it. So in Sokoto State, I believe there are 351 routine immunization health facilities that we call APEX. So those are the facilities that the state is focusing on in terms of, supplying vaccines, right? So of course, there are more than that. So I don't know how many facilities in Sokoto State. The total, both RI and non-RI, and also those with cold chain and without cold chain. Yeah, so over 800, but the ones that have cold chain equipped, the one that the state is focusing on is 351. So vaccines only go to those places because those are the facilities that have cold chain. And the determination of which facility has cold chain usually is determined by the national policy. That at least when you're distributing your cold chains, you should consider the one functional PHC per ward so that you ensure there's saturation, there's equity issues being addressed, and that the cold chains are being deployed to, the right places.
All right.
Yeah, thank you.
All right, thank you very much. Can we just take one more question? Okay, it's just one. So this will be the last question so that we can take a final charge. And
my name is Shiva Gabdidam, and I work with Sedani Group. My question is a broader question. I hear and see the beautiful interventions, technological solutions that have been presented, addressing different challenges per time. But my own burning concern is how are we working to ensure that there's integration of all the data that we're collecting across these multiple platforms into existing platforms? Because there's the challenge of while you are improving or improving the use of technological solutions to solve problems, there's also the part of you don't want to also create parallel systems. You want to build on existing structures. So, and this is a broad question and it goes to everyone in the house. In designing these interventions, in building these systems, how are we thinking about integration into existing systems, strengthening existing M&E systems? Because the problem of, having M&E systems that are running in silos, and this speaks across the entire process of data management, from data collection to analysis to reporting to feedback and all of that. How are we ensuring that we plug back and generally work to improve the health system strengthening of a particular area? I love to see to ensure strengthening to achieve improved uptake of immunization services. So how are we tying all of this into the broader picture? That's my concern. Thank you very much.
Okay, just an attempt to respond. Thank you for that very valid question. And I think if you had been following the conversation right from the morning, it's actually evolved around what you're saying, right? And we need to take some of the key highlights from the panel conversation into consideration. So basically, the major issue facing Nigeria, not just Nigeria, let's say within the African region, is the fact that we're having more competitors than partners in the digital innovation space. I was actually in a similar forum organized by GIZ and ECOWAS, and this pops up again. And I summarize it this way, that we need to come to a point as a country where we are less competitive and become more complementary. So that is what it is. And that's why we're setting out this forum. And I think by the time I speak in the next, how many minutes, I don't know when, TJSU allowed me, is actually the wrap up of this entire session and to tell us what is the way forward, because this is not the end of this conversation. That's why you could see the different players in the room here. They didn't just subscribe to coming here just because they just wanted to come and show themselves. It's because we're all in agreement to achieve that level of uniformity within the digital innovation space. And it's a journey. And we'll definitely, let's say the journey had commenced and we'll see what it looks like. Yeah, thank you very much.
Right, thank you. So as I think I'm just going to entertain just one more question for the sake of time, while Dr. David prepares to give us his own presentation. So can you please just shoot from over there? Yes.
Good afternoon, everyone. My name is Kemi from Elinkena International. I just want to add to the questions that he asked about data integration. I just want to give an example to help us to understand the angle is coming from. For example, we implement vitamin A supplementation and we collaborate with National Primary Healthcare Board. But one of the challenges that we are having is that, okay, we have set up different data tools and putting technology to give us results at various levels. But one of the issues is that this data that we have gotten or the primary health facilities have generated during the MNCH week is usually a large amount of data, but we don't see it transmitted to the DHIS tools. We did our findings from the primary health facility down to the wards, the LGA, and then we have what we call the calling data that we use to visualize the entries of data and analysis and visualization. So we'll go through the stages of data reporting, but at the national ground, which is the DHIS tool, the data is over-reported. So I want to know what we, the state, the primary healthcare board, and also the other implementers actually doing, because when we implement, we generate data, but these data are not actually showing the result of the efforts you are putting in place. So what are we doing to ensure that at the national level, the report is being shown as it is at the facility level? We are getting this data, we are implementing, but we are not seeing it at the national level. So what can we improve? Should we improve on the health facility, community, the health workers improve on our capacity, or we develop technology to transmit this data from the facility down to the DHIS? Is there something, there should be a gap to bridge this discrepancies that we are having? That's my submission. Thank you.
All right, thank you very much. So right now I'll be bringing up the Deputy Director Programs and Impact at eHealth Africa, Dr. David Akpan. Just like he submitted not too long ago, some of the answers to these questions are embedded in the next presentation. So I'd like us to sit back and listen to him present on digital health strategy and technical working group.
Thank you so much, TJSU. Thank you very much, distinguished audience and participants. mine is not a long presentation, right? It just to summarize all the thoughts, the thinking, the conversation, the ideas, and more importantly, the insight that have been generated from this meeting. So I just want to let us take note of something, right? Whether as different players and actors in the space, we're discussing digital health because this has come to stay with us, right? So it's no longer myth, it's no longer misconception. So it means people have welcomed the fact that digital health, it's gaining ground and is actually growing into a different part of the healthcare work. I love the interests that have been really come out from different quarters around some of the digital health innovation that had been shared today. And that's actually for us led to the fact that we needed to have the forum of this nature, because we want to make sure that when we're talking about digital health in Nigeria, we're talking as an entity and not as individual innovators, right? So this forum is to help us interact, and that's why for us this is a maiden edition, just to share what people are doing at different space. And then by the time we grow this, we will definitely get to a point where we're building what is so much talked about, the interoperability, the integration, the alignment within partners. I can also tell you that some conversations have come out of this meeting, even being dragged outside by different partners, and the executives of organizations out of this meeting. Now, which means that there have to be some form of strategy to implement this. Good thing we are not thinking of something new. What we're actually working here or working towards is actually to implement the global digital health strategy that has been designed by World Health Organization as a standard practice that partners, organization, players, stakeholders are supposed to help countries to achieve them. And that's what EHA as a frontliner for Nigeria, and we have a couple of other countries coming, is trying to roll out this kind of conversation. It is by that opportunity, I just want to share just some form of snippet or snapshot of what that strategy really emphasized. So next slide. So there are 4 guiding principles that particular global digital health strategy had pointed out. And these are things that should go in everyone's mind. Number 1 is that we need to understand that there is actually emphasis around institutionalization of digital health. What did that big English means is that digital health is supposed to be owned by the country themselves, not by the players. It's supposed to be owned by the country themselves. And that's why we're so glad that pharmacies Mutala had to come in from the government perspective to share how they are using the LOMIS in the vaccine direct delivery program. And that's what institutionalization of digital health is all about. Because if you don't do that, you cannot achieve the sustainable application of digital health in the space. And that's what the emphasis of the strategy. And he said that has to happen within the national health system. So the emphasis for us is to make sure that we don't pull this program or take on our different digital innovation in silos away from the health system in itself. That's the key emphasis, right? And because that's where decision and commitment comes from. Because if it's not part of the health system and you're trying to get the government to take critical decisions on how to use your data to inform national planning, they cannot. Because your data to an extent might just be your own prescriptive idea of the issue that the government need to think about. But if they are owning that data, they can rely on it and it should inform national planning. And we all know that, I mean, when government want to plan different programs like we are in this new dispensation in Nigeria, there's actually breadth in data. And some of the planning our assumption. We all get to face the last, the current issue we're facing with, what we're facing. So I have to leave it there. So which means that if we had data that is open to people to help national planning, decision would have been more effective than the way it is. But do we know how people don't have this data? There are private players who have the data, but these data are not available to government. So let's not overflow that. But those are the guiding principle in the entire thing. And then we need to recognize, still on that same page, we need to recognize the fact that successful digital health initiative requires an integrated strategy. So when you are doing your own aside digital innovation, do you think of bringing it to the larger pool of the central data repository? So you always need to think through that you can't have your digital innovation to be away from other people. Like we all agree. Yes, I think listening to all the innovations that have been shared here, I'm already identifying innovations that can build interoperability, integration. Rather than having 6 of them, we would have most likely be having digital suite, and all of them being model of different areas. But we have one solution, that is called a suite, and then the rest are just modules under that suite. But they are all being driven independently. So our conversation is that when we are designing innovation, we should think of an integrated strategy. And that's very important because there's no benefit in staying independent in the space. Absolutely no benefit. And that's why we're driving these conversations to see how we can come together. We should promote an appropriate use of Abdurrahman. Just calm down. Don't worry. I'm wrapping up. Appropriate use of digital technology in health. There's actually what is called the misuse of digital technology in the health. I don't want to dwell on that, but studies have shown that so many digital innovations are not for the intention of the client or the beneficiary. They are for the intention of the developer. That's a lot to say. Yeah. And that's why some of them do not protect the proprietary information of the client. Like someone was saying somewhere in social media, someone calls you up and said, I have a job for you, and start reading everything in your CV. And you ask yourself, did I submit my CV to you? He said, no. So how did you know the content of my CV? He said, that doesn't matter. You had submitted the CV somewhere else and it leaked out into another person's hand. And some fraudulent guys are now using it to, achieve some aim. So that's what happened. People just sent out forms, Google forms, survey forms, and people complete it without thinking of the client privacy in mind. And that's key, right? And we want to make sure that we have a way of addressing this. Then the urgent needs for addressing such impediment is also important. So these are what WHO has highlighted. So let's look at some of the core areas of interest for WHO if we want to address this strategy. Next slide. So the first one is that we need to promote global collaboration. And this is what we're talking about. Ours is national collaboration. And that's what we started off this forum. And this is to advance transfer of what? Knowledge on digital health. And I'm sure a lot of people have learned from each other, what people are doing differently, from what you know and what you've been doing. I saw a couple of innovations here like EQs, Topigo, innovations looking very much similar, but in different setting, you understand. And one could look at it and say, hey, my innovation did not cover this. And I think we need to go back to it. And that's the essence of having a forum of this nature. We need to advance in the implementation of the digital health strategy. Nigeria have what they call an ICT strategy. I think you heard that from Dr. Emeka, who had the initial draft actually became a bookshelf document. And then they did a review and they have a new draft who had gone through, I think I just heard or been updated a couple of weeks back that has been approved. And it might likely be the same thing if we don't have conversations like this to take those kind of things forward. And that's what it shouldn't be that way, because countries have moved further. Pausing for a minute, Nigeria would have been the digital health hub for West Africa, but we are not. Hello, we are not. I can tell you the country being a hub for West Africa and out of West Africa is Rwanda here, Kenya the other way. They are the one coming to Nigeria to show us the way. That's the truth. It's because we've not had a wake-up call with our government thinking through how do we embrace digital health and begin to spread the benefits across West Africa. That's quite key. In fact, we were talking to some of the executive here and we said, this meeting needs to go above this level and we need to talk about it at higher level. And that's the truth. So the conversation has been actually interesting and we need to move to that. And that's the third point, strengthen governance. So we are lacking governance in digital health in Nigeria. And that's the critical point for us. We want to make sure that that happens at national, it happens at state level, and we want all actors in the space to make a commitment for that. Don't just train your users. We're not talking, when we say governance, we're not talking about users of applications and innovations. We're talking about decision makers who need to take decisions on the use of those applications. So those people need to be factored into this kind of conversations or whenever you're talking about digital health. And then of course, we will always, or we need to advocate for people-centered healthcare system that are enabled by digital health and not a system that are driven by partners initiative, by donor initiative, but it has to be about the people, about the people. If you're bringing in innovation, the question is that, are the users going to be comfortable with this, all right? And these are areas that WHO had found very interesting, kind of highlighted to prioritize. As an organization, eHealth Africa, and then starting off with this conversation, we are taking a most likely, I wouldn't say lead, we are facilitating conversations around the first objective, strategic point, around leading and promoting collaboration and knowledge transfer. And that is why this particular meeting was set up. We're starting off here in Nigeria. I think before the end of the year, everything being okay, we'll possibly push it to Sierra Leone. And of course, by next year, we'll do it in Cameroon. And it doesn't mean that it's a one-off exercise. We're already having interested players and partners who want to join hand with us to strengthen this kind of platform to be an annual exercise. If you're part of those people, you can raise your. Are you in support that this should be an annual exercise? You love it. Or we should do it monthly. All right. It took a lot to put this through, and I will come to that point when we're closing. Yeah, so that's for us the idea. We need to make sure we talk more, about how we can run these strategies and those initial guiding principles more effectively. So the final action point away from this meeting, my final slide, is that we are hoping that representatives from different organizations who had attended this very maiden edition of the Digital Health Insight Forum are able to express interest again to be part of the digital health. Next slide, Abdurrahman. Yeah, okay. I think I've touched on some of this. Let's go next. Yeah, really get to be part or subscribe to us having Nigeria Digital Health Technical Working Group. So that's what we're proposing, right? That we should have a digital health technical working group where we are sharing more information. We are actually ideating. We are brainstorming on ideas. So in the coming weeks, communication will be going out further to the different organizations just to send some representative, one who are actually enthusiastic about digital health. Because if you're not, it looks boring, right? So if you are, and then some people are also technocrats who can communicate in the program way, and then the technocrats who are technocrats. So it's a very a good mix. But what we're looking forward is representative of different organizations who can come to join very much brilliant heads together and see how we can drive the digital health conversations in the Nigerian space. We're hoping that by the time that is being inaugurated, we should have some quarterly innovation forums, right? Where we brainstorm what happened. Now, remember, this will not be a forum where we are seeing ourselves as competitors. These are forums where we are seeing ourselves as allies, because we're building for the Nigerian space, not for ourselves. Which means that if an opportunity comes, maybe from form of support, let me give you an idea. A couple of conversations have come up even by the side that we could have 2-3 organizations just look at issues within Nigerian space that need some form of digital health innovation. And we pull all of that together, put the thoughts together, put them as a concept paper, and go as a team to a donor to say, this is what we have teamed up to find out and innovate about this Nigerian space, and we want you to support it. A lot of donors will definitely buy into that idea than if you had gone as a single organization. So that's what we are aiming to achieve, that if we have this group, we can ideate, conceptualize it, come with one concept paper and say, source for donors. That's donors almost everywhere looking for kind of innovations of like that to support. And we hope we get to achieve that. And then that will be a beginning and an initial step for us. And then finally, that group, because of some of the work that we might want to bring out, wouldn't stop us like advising government in terms of policy directions around digital health. And that document can guide even some donors, some partners to think of additional things on how they can do things. So that's basically what this conversation is all about. If you've been excited about this conversation, just like myself and the teams that put this together, and your hand is not busy, can you clap for every one of you? Yeah, thank you. So if you're in support of this motion, say aye. Okay, if you're not in support, say nay. Okay, the ayes have it. All right. No, I'm not in that. I think we just go with the self. All right, I think basically that's the point at which we will bring this particular initial gathering to a close. And I'm actually standing in another capacity to do this. And we want to sincerely thank all the participants and very distinguished ones for that matter, who had on their own, I know people who had spent personal resources, organizational resources to be here. Those are commitment we're talking about, right? And we really appreciate you for making this kind of commitment. And that's the spirit we want to really, really grow and most likely motivate some of the work that, or the discussions I just talked about. So thanks very much. And we thanks to our participants who had been online for these long hours. It's not easy to be online for a couple of hours if something doesn't interest you. So thanks, very sincere. I have been a hybrid participant. I've been here physically present, joining online, so that you're able to also help the technical guys to to really find out what is happening at that other end. And that's very interesting to see that people are on since morning till about, I think about now. And that's quite interesting. And that's the conversation. So these conversations, like I said, continue. Not looking out for EHA, but look out for the Nigeria Digital Health Technical Working Group, because that's what it's going to look like, right? And that's what is going to form the basis and how we're going to move this conversation forward. Like you heard from, I think TJ Suen, he did the intro. This particular event marks our first anniversary of the Insight webinar, which holds every last Wednesday of the month. And today is the last Wednesday of the month, isn't it? So we have a webinar series, public health webinar series, not digital health, right? Public health webinar series that holds every last Wednesday of the month. So if you follow us on our socials, you will definitely get to know a lot more about that. I think the next one is the last Wednesday in August, and we don't get to miss it, except it's a public holiday. And then we move it the following week. That's how it's been. And thanks to all the team that has been able to put this together without possibly making reference. I think distinguished colleagues and all the units that I worked. And most, I think at this point, I have to recognize that one of our team who had really pulled this through, and that's our communication team. Please, if you don't mind, appreciate them for me. They've gone through a lot to bring this together, sincerely, and they are still doing that. And then our help desk ICT team, they've been fantastic. Just for you to know that this event had been streamed live on all our socials. So you've been here and all your pictures are online. And massive participation outside, massive. Like I said, I was a hybrid participant. So I can tell you from a point of knowledge, not assumption, right? And that means that a lot of recognition has taken place. In fact, people are asking for the presentations, all right? So I'm sure you'll be able to pull that together. And that reminds me, we're going to create a Google Drive or folder for all the presentations. And if your emails were rightly written, not wrongly written, and that's why most time when you go for an event, you need to make sure you pay special attention to writing your email and well, let it be very legible to the eye. So if it wasn't rightly written, I don't know how we're going to handle that, because what will happen is that we want to put together the pictures, the presentation from this event on a Google folder and share the link with all the participants that registered for the event, so that you can also have that as part of it. So on that note, keep it short, keep it brief. I want to say thank you. And that brings us to the end of the event. And let's get to see again any other time we get to meet. Thank you very much, everyone. I understand that the next item is another photograph. Is it? Cancelled. Okay, the next item is to go and make sure you launch out. Thank you very much.
All right. So for launch, you must have received the ticket, and the launch stand, I believe it's outside. So you'll be directed there. Sorry.